thanks for that robust applause. I appreciate it. I already feel the love. I'll just say a few things about myself to set the context while the rest of the folks have a chance to sit down. I've attended, by the way, many conferences in this room, so I know I didn't know what f-stop was on a camera till a few weeks ago, but you sit in this room, you know what it is, right? It's hard to keep everything in focus the entire length of the room. So I don't have any slides. Anybody relieved at that? Yes. The people in the back of the room can say thanks. I have unprepared, prepared comments. What that means is, and in my introduction I'll say that I practiced law for nearly 30 years. What you learn pretty quick in the practice of law is what you say, people don't really much remember, except in the context of what the person said in front of you. So having listened to the panel in front of me, I've already on the fly changed some of my remarks to make them more relevant to what you all have been talking about. My name is Dan Evans, Jr. I'm the CEO of IU Health, a not-for-profit corporation, the members of which are the Indiana University Board of Trustees and the Methodist Church of Indiana. I was a practicing lawyer for several decades at Baker & Daniels, which is across the street, a few blocks away. I had to go through Ice Miller to get here, our main competitor. But since my license is now inactive, I don't much care. I used to care, but I don't much care anymore. I'm going to speak, I think, for 20 or 30 minutes, or maybe less, and then hopefully have a bit of a dialogue. My purpose is to share with you a few thoughts about innovation in the delivery systems that may be going on both in Indiana and elsewhere in the country, but more particularly at Indiana University Health. But my main purpose in being here is to say thanks to each and every one of you for showing the interest in appearing and spending this time together to talk about and listen and participate in what I consider to be the seminal issue of our time. That is, how are we going to take care of ourselves as we confront the reality of actuarial science and demographics? We can do all the denial we want about both of those things, but the reality is upon us. If I can be personal for just a minute, a few of you already know this. In the last 72 hours, my wife broke her leg, my mother-in-law had a stroke, and my brother had open heart surgery. So I have been at the epicenter of the system of which I am the CEO. So my sensitivities and sensibilities to coordinated care, medical informatics, biostatistics, and innovation are attenuated. My brother's defect is genetic. Our father died of the same thing. Between now and then, innovation has made it possible for people to live. My mother-in-law's stroke 2 days ago could not have been diagnosed in the town where she grew up, Sullivan, Indiana, because her mother died of a stroke before they could transport her to the nearby tertiary care hospital. My wife's break on Sunday was non-dislocated, so it's treated with an air cast. A few years ago, it had been treated with a hard cast, and she would have been unable to walk easily for months and months and months. So what part of those three examples of innovation would you like to not pursue in the future? You tell me. I'm at the retail end of the business. Our political leaders and our government has decided the way to control healthcare costs is to constrain expenses, that is, reimbursement. And in fact, the Budget Balancing Commission, whatever the hell they call it, the Deficit Commission, last Friday was the deadline for it receiving ideas from anybody who wished to present ideas to be considered. You may have read in the Sunday New York Times that virtually all of the ideas which were submitted were, don't cut my program, cut somebody else's. On November 23rd, it must report its recommendations. And in the third or fourth week of December, Congress is supposed to vote up or down. How many folks in this room, you don't have to raise your hand, how many folks in this room believe this commission is going to arrive at a consensus vote? Answer that in your own head. My own head tells me no. And even if they did, Congress would vote down in December. Then what happens is a 2% cut in Medicare reimbursement to all providers. That's the solution. So our society has decided to use that apparatus to impose upon me, the CEO of the state's largest system, the legal duty and responsibility for rationing your care. That's what society has decided. So we must decide at IU Health how to deal with that. So that's what I'd like to talk about, is innovation on our end of the business. Professor Levin in 1959 wrote an article in the HBR entitled Marketing Myopia. So here's the question. Are you a railroad company or are you a transportation company? Are you a movie company or are you an entertainment company? Are you a telephone company or are you a communication company? Are you a hospital system or are you a healthcare system? Well, what we are in the middle of right now at IU Health and all the other bigger systems in the country is morphing ourselves from something that is intently focused on tertiary and quaternary care. In other words, the treatment of my brother's heart today to a system. Whereas will my brother be compliant tomorrow when he gets home? We already know that 50% of men don't fill their prescriptions when they leave the hospital. 50%, and the remaining 50% of those don't take their prescription to its conclusion. So you're down to 25% or 100% compliant. So forget about personalized medicine and all that stuff. You could improve the efficiency of healthcare immediately through medical literacy. And there was a brief allusion made here at the speaker's table to that, and that is the complexity of compliance later on. We can say all we want. If our typical patient is an older person with 4 or 5 comorbidities, or a woman, and you know what I'm talking about, coordinating the health care of her children, her husband, or her parents, and what she gets at the end of the day when she leaves the hospital is a sheaf of papers as to how to be compliant, the chances of compliance are nearly zero. Now, my brother, my mother-in-law, and my wife are the mother-in-law, the brother, and the wife of the CEO of the system. So everybody is bending over backwards to make sure that their care is flawless. But I know the risk is not now, the risk is in the future, as in tomorrow and the next day. So I've got to figure out a way to make the healthcare system that I serve husband the resources that we get in a way that I can maximize their benefit to as many people as possible. The comment that was made about Alzheimer's. And if we had a vaccine for Alzheimer's, we wouldn't be worrying about EMRs. We'd be worrying about whether or not we can make enough of it and get it distributed soon enough. I have on my desk a photograph taken of me on April 19th, 1955, at 38th and College in Indianapolis, getting the first commercially available polio shot in Marion County. It was on my dad's desk until he died, and as we cleaned out his stuff, there it was. Did a little research with the paper, and it turns out it was a black and white that was in the paper. I asked my mom about it, and she said, honey, in 1955, we didn't leave our children alone. We didn't go away on vacation. We didn't let kids get in the pool. We didn't do any of that stuff because we were afraid they'd get polio. And enough of them did that it was a very real fear. That's eradicated. That is gone, except in third world countries. Who in this room would have denied Dr. Salk the research money to arrive at that conclusion? That was an example of leadership of the President of the United States in the 1930s, a polio victim saying, we will cure this disease. So this society has the capability of being innovative in spectacular ways. Where we are stumbling right now is at the retail end, the end that I deal in every day. The role and mission of IU Health is trifold: education, research and innovation, and clinical care. So we do all 3 of those things. The challenge is one informing the other, so it gets to the bedside and people's health status is actually changed. We use many techniques to get to that point. But what we've ended up with right now is that care is fragmented, uncoordinated, and reactive, and the quality varies greatly. So here's our vision for a statewide system. One standard of care, every place, all the time. Every hospital in Indiana that you drive by has a sign out front, right, that says emergency room. We have some IHA officials in the back. Anybody dispute that? Oh, I think they left. No, there's Doug right there. Everyone said, Doug, you can't quote me on this, okay? I'm sort of a Nazi about this. I think signs in front of hospitals ought to disclose what's inside. And they sure as heck shouldn't say something is inside that's not there. So I believe every hospital in Indiana ought to be part of a coordinated program to provide care in case I have a heart attack right here, right now. If I were standing in some communities in Indiana, I had a heart attack right here, right now, I'd be taken to a hospital that doesn't have an interventional cardiologist or a CAT station on duty at that moment. I'd be imaged up, I'd be diagnosed, I'd be stabilized, then I'd be put in a helicopter and sent someplace. In the meantime, an hour or two passes and heart muscle is dying. Indiana is the smallest state geographically west of the Alleghenies. There's no excuse for every hospital in the state of Indiana to not be networked in a STEMI program, ST elevated myocardial infarction. So if you're having the big one, you can go straight to where the expertise is. Now that's not medical waste, or is it? To permit every hospital to hold itself out as if it can do every service because the sign in the front says emergency room. I don't criticize my colleagues because we've got some of those hospitals in our system where we put the sign out, it says emergency room, but there's not an interventional cardiologist on duty at that moment. So, back to information. That's where I'll start. There's no clock here, so I better take off my watch or I'll go on the entire afternoon. And I don't detect much energy for that in this room. And I didn't tell a joke at the beginning. Anybody want to hear a joke? Yeah. Okay, good. I told this yesterday at Rotary, got a laugh, and I told it this morning at an autism conference, I got no laugh. So you tell me, old lady goes into the pharmacist and said, I need some arsenic to kill my husband. Pharmacist said, you know, I can't give you any arsenic to kill your husband. She says, look at this, and reaches into her purse and shows him a picture of her husband and his wife in flagrante delicto. It's a legal term, you know what it means. Yeah. He looks at it and says, oh, you didn't tell me you had a prescription. It's a joke. It's a joke. I told that to some farm techs about a year ago. They did not think it was funny. So something happens. The humor gene is taken out somewhere along the line. But the Rotarians thought it was great. But the Rotarians start every one of their meetings with a corny joke. So mine was just part of it. So information. How do we get information into the hands of the patient immediately? You're having a heart attack. Are you going to go Google cath, door to cath time? Your daughter breaks her knee or hip on the soccer field. You're going to race and compare imaging costs? You can't read, and you've got 7 kids and don't speak English, and you're an undocumented alien. Are you going to call up the reference library at the Indianapolis Public Library and ask for the number of cases that have been handled? So who's the intermediary between me and thee? Who is that? That's where the healthcare reform, as one of the previous speakers said, has really failed. It has not brought the patient into the equation in a meaningful way. So it's up to us, that is, being able to broker information and make decisions. So our market research tells us that something called Indiana University Health can be trusted. It's a place where they should feel assured that they're getting the best care. So the question for me as the CEO of the system is, are they getting the best care? We have the vision, one standard of care, every place, all the time. We benchmark our outcomes against the 90th or 95th percentile of the University Health Consortium. That is all the big academic medical centers in the country. And if we're not there or on our way there, I cannot recommend to my friends, neighbors, and family members they use one of our own facilities. So here's my test. This is unscientific, although it's based upon data deep down. I would not recommend to anybody they use our facilities unless I would send my mother there. Simple. Anybody disagree with that? So when you call me, as several of you have done out in this room, and you ask for advice on a tough decision, I'm the one who has the data. So I mine the data and I give you a response. And this response is variable right now. So and you've got some experts sitting in this room. So medical information has to be developed in a way that can be consumed by those who serve the public. It is a tall task to expect the public writ large to consume that data and use it. Now, I'm just about to impeach myself in that regard. So here's the caveat to that. I'm an old guy. I'm 62. So I'm in the 7th decade of life. I get the discounts now at movie theaters and at the car wash without asking. Remember when that happened to my dad? He said, "This is not good." And then they'd ask him for his name so they could bring out his stuff. They'd say, "What is your name, sir?" And they meant his first name. He'd always say Mr. Evans, and we'd all die and so forth. I'd say, "Dad, they mean your first name." Now I feel the same damn way. You know, I'm not Daniel, I'm Mr. Evans. You're just some kid. Bring me my cheeseburger as soon as you can. So how do we take that information and get it to the patient and to the decision makers, and how do we steer people in a way that they get the highest quality outcomes? This is really the challenge in a place of innovation. So what is the innovative tool that we're going to use? A lot of talk, and this is the main point of my talk, a lot of talk today is about accountable care organizations and medical homes. We had an aha moment the other day when I had the CEOs of all 20-some of our institutions in the same room. Some of the CEOs run our risk-bearing organizations, that is the insurance companies and the prepaid plans and Medicare Advantage. But most of our CEOs run hospitals and the clinical end. The aha moment was when they realized success for the risk-bearing part of the enterprise was failure for the clinical part of the enterprise. And success for the clinical part of the enterprise was failure for the risk part of the enterprise. And here's what I mean. Here in the Midwest, our culture is maximal use of healthcare. So we have a very high utilization rate here in the Midwest. In some Indiana towns, you spend the afternoon, if you're a retired GM employee, paying your dollar and going to see the doc. You're an overweight diabetic. So we have a very high utilization rate. When we accept risk, Medicare Advantage, and they say to us, "We'll pay you X number of dollars for this population, the U.S. government," we agree to manage the health of those people within those dollars. We don't at IU Health. We spend more than those dollars because for the people who are providing the care, our hospital guys and our doctor guys, those are heads in beds. Those are good things. For our insurance guys, those are overutilization. So how do I, as the CEO of the system, get the two sides of the house to talk together? You remember 20 years ago, HMOs, Hillary Care, this was rationing. Death panels didn't come up 2 years ago, they came up 20 years ago. So there are learned people writing pieces about ACOs today, John Goodman comes to mind down in Texas, saying, well, that's just the HMO redux. But 20 years ago, my mother was 20 years younger. Your mother was 20 years younger, and the probability of her dying within that 20 years was higher than it is now. So the big difference between now and then is demographics. And we have not prepared ourselves for that reality. It does not. In our system, we are now receiving routinely septo and octo and nonagenarians with 4 or 5 comorbidities whose families really don't have the capability of coordinating the care. And many of you in the room have gone through this because I know you personally with your own families. This is very hard work to maintain compliance with difficult regimens. Went out to dinner last Sunday, I think I referenced this, with an old family friend who's 90 years old and his daughter had gone to Boston to work. And I noticed on his kitchen counter, he had his pill box and it had 17 containers on it. You know, he had the week, is what he basically had. And I thought, wow, what happens if he drops this thing because he's arthritic and so forth, and he lives alone? And no way is this old man going to move in someplace. So he'll probably die in his condo and cost society nothing. So which part of the innovation between then and now do you want to get rid of? My grandmother in Frankfort, Indiana, my mom's mom, lived in the dining room when I was a boy because she couldn't go up the stairs because she had bad hips. My mother and my aunt, her 2 daughters, between them have had their hips replaced 4 times. So my grandmother cost society this much. My mom and my aunt are Medicare, I suppose tens of thousands, if not hundreds. Would you not want that innovation? And in Indiana, 35% of the implants are made in Kosciuszko, for the world, are made in Kosciuszko County, Indiana. So let's say we did what they do in other parts of the world. We made it slightly more difficult to get those implants. In other words, there was a queue. You had to wait in the queue. And demand for implants went down. The first thing that would happen is demand for production in Warsaw, Indiana would go down. Then David Johnson would start getting calls from Warsaw saying, how can we juice up the demand side of this curve? So we have now what President Eisenhower talked about 50 years ago, except that it's not a military industrial complex, it's a medical industrial complex. The difference between the military industrial, I just made this up by the way, I kind of like it. The difference between the military industrial complex and the medical industrial complex is the medical industrial complex is going to save my brother's life. I'm in favor of that, aren't you? But I'm also in favor of my brother being compliant with his post-acute care treatment regimen. I'm also in favor of that. I don't want him to be readmitted within 30 days. If he's readmitted within 30 days, now he's not Medicare, but if he was readmitted within 30 days with for the same reason as he was admitted in the first place, we wouldn't be paid. In the past, readmitted, we just get paid more. That's the two sides of the house. It works. So what are we suddenly responsible for? We're suddenly responsible for my brother's compliance, which means we have to do something really hard. We have to call him the day after he gets discharged on the phone. The phone's been around since 1874. And ask him, I just made that up too, maybe 1872. But it's been around a long time, and we're now asking our staff, could you please call Mr. Evans within 24 hours of his discharge, ask him if he filled his prescriptions, if he has any questions, and is he on his drug regimen? Never made those calls before. But the operation was a success, right? The heart transplant was, the aorta replacement was perfect. The surgeon leaned over to him and said, you know, David, long after your ashes and the archaeologists dig you up, this artificial aorta will still be here. And David said, is that supposed to be funny? And he said, no, yeah. He said, no, this is an example of innovation. I have on my desk, and I looked desperately for it. I was going to pass it around, the 1964 Methodist Beacon newsletter. On top of Methodist Hospital is a lighthouse, so the newsletter was called Beacon. It has a picture of the dog getting the first bypass surgery. It also has the annual report of Methodist Hospital's income in 1964. Average daily census of 818, huge hospital. Revenue, $15 million. $15 million. Today, IU Health's daily expenditures are $12 million. A day goes out the door, $12 million a day. Methodist is about 25% of that. It's about 20, 25% of our system. The difference was in 1964, they weren't doing heart bypasses, heart transplant, end-stage renal disease, fancy brain operations, they didn't exist. So innovation has made it possible as this demographic reality has confronted us to treat things that we haven't treated before. And what we find ourselves now is in the fog of multiple choices for which our society is not available. So here's an innovative idea. Have your staff call patients at home within 24 hours. Will that cost us anything? Absolutely not. Here's another innovative idea, and I think what time am I supposed to end? 1:10, 1:05? 2:30? Okay. Okay, 1:50. I'll be done before then. One man's waste is another man's necessity. We know that about a third of care and end of life is futile, that it makes no difference. That's your decision, not mine, in our culture and society. But my responsibility is to call it out and say that palliative care and hospice care have a place in our society. And that's a conversation I hope you'll have next month. This is a homework assignment. Next month at the Thanksgiving table. You don't want to do it. Trust me, been there. You do not want to do it, especially if you have elderly parents. You don't want to do it, but you must. 50%, I know it's going to sound like I'm saying 50% a lot, it just happens to be true. 50% of living wills are ignored. Here's why. The family's ambiguous. You're the doc or the hospital. What would you do if the family's ambiguous? Extraordinary and heroic methods. I'll tell you who that hurts, the staff and the patients. So I believe, and I believe with my own family, it's a little narcissistic on our part to expect the rest of society to help us in those extreme circumstances. Easy for me to say. My dad dropped dead of a heart attack. Easy to say. When I walked through the cardiac critical care, which I did today, I saw 3 families that I knew in addition to my own. Trust me, I didn't walk in and say, have you signed a living will today? But 6 months ago, I would have said, had I known they had an elderly parent or an overweight husband or something like that, do you happen to have, because it's okay for me to say this as a hospital administrator, do you happen to, and a lawyer, do you happen to have a medical power of attorney? But what happens is, even those with the medical power of attorney don't have the conversation. So you can talk about all the fancy schmancy innovation you want, which is great, which is wonderful, which has helped my brother, my wife, and my mother-in-law just in the last 72 hours. But you need to have the other half of the conversation that was alluded to this morning. What is your responsibility at the end of the day? And I think that's an area of intellectual exercise that Aspen Institute and other leading think organizations in our country need to address, because at the end of the day, I believe the challenge in healthcare is a social challenge. Innovation will proceed apace. We have 4,000 clinical trials ongoing at IU Health right now. The citation number that was mentioned a minute ago, we probably produce, what do you think, Bill, 5 or 6% of that is a big AAU university. Some of those are studies of studies, but a lot of them are not. After the doc called me yesterday about my brother, I actually looked up 2 recent studies about what exactly he described to me my brother's aorta looked like. And there's ongoing research about how to identify this particular genetic defect earlier in life. Between my brother and me, we have 7 kids. So what am I thinking about right now? Is how can we use innovation to diagnose my kids, not my mom? This is really important. So here's my final thought. This is my final thought, I promise. In our society, we're betwixt and between today. We're betwixt and between on the innovation as it applies to us and our elderly parents, no doubt about that. But we have decided as a society to allocate scarce resources to older folks. We have decided as a society not to reward innovation for younger folks. So, if you need a coronary assist device at Riley Hospital, you don't have 20 or 30 to choose from. You, in fact, I believe, have none. And we acquire them from overseas. I don't know if that's true today, but the last one I was aware of a few years ago was a Berlin heart. I asked one of the guys, why is this called a Berlin heart? And he said, well, it's from Germany. And of course, the reason is ARP and Medicare are not lobbying for reimbursement codes for innovation for things for kids. They're lobbying for, us. And for us, that's just fine, right? So here's my last thought. I had the privilege and the pleasure of working for Governor Bowen as a volunteer when he was Secretary of HHS. 2 lawyers from Baker and Dales. We went to Washington on a pro bono basis. We'd been his campaign chair and his campaign manager in 1976. And Doc was a Hoosier doctor, and he had all these Washington guys. He wanted to bring some local boys with him. So we went out there and interviewed with him. The first big thing we learned was the budget of the immediate office of the secretary was greater than the biannual budget of the state of Indiana. And a rounding error was $500 million. And Doc said, wow. We also learned that Margaret Heckler's predecessor had a hairdresser's office in her office and a private elevator. Doc got rid of both of those. I mean, actually drove himself to work until the security people told him he couldn't do that anymore. But Doc was a country doctor. He knew about actuarial science long before anybody here started talking about it, so he lobbied President Reagan, not a known liberal, that we need to raise taxes on elderly people of means to pay for their own damn Medicare if they had a catastrophic incident. Means-adjusted Medicare. What a revolutionary idea. I think there's 17 members of the cabinet or whatever. The vote was 16-1 against. And this is all chronicle in a book that's been written about it. Of course, the only vote that counted was President Reagan's, and he overruled all the others, and the catastrophic care tax became law. was either 87 or it was right at the end of the Reagan administration. It was repealed 1 year later after ferocious lobbying by us. So here's the psychosocial problem. We think it's free. And we think we have no responsibility for it. So how do the thinkers, we would call ourselves the cognoscenti of healthcare. A few of us might be the glitterati, but that's a bit of an exaggeration. So I feel the responsibility to use the same innovative juices that we've used to invent an artificial aorta, to invent a way to re-educate society to deal with what is a train wreck that's just about to bankrupt all of us. I believe we're on the edge of a healthcare bubble. Not like the housing bubble, but pretty damn close, where one day, we wake up at IU Health and say, you know, we didn't get paid last month. One day. Today I got a call from the Federal Reserve, my last comment. They're having their annual regional meeting and they want to hear, you know, what's going on. And I said, bad debt, guys, bad debt. All these employers are raising their deductibles on their employees and they're saying they're lowering health care costs. No, they're not lowering health care costs a nickel. You heard it here today. That's not true. People are either deferring care and going in sicker, or they're not paying their damn bills because they can't afford it. LaPorte, Indiana, the average municipal worker's average deductible is now $12,000. So they're self-insured. So what happens to our hospital in LaPorte? People don't pay their bills. And what do we do when they don't pay their bills? We shift the cost to you. You're the actuarial risk pool. So that is my closing, final thought. I think I have 2 minutes for questions if you dare. Any thoughts in the back of the room? Surely I didn't. The other panel got questions. This would be really embarrassing if I got no questions. Good, thank you. Clayton.
Read his book. I asked some of the other speakers this morning. He said it's to start with fee-for-service and blow it up, not have Medicare set rates, and then insurance companies will drop 20% up on that to pay their providers. That's where we've got to start with it, and then complete it with a technological innovation of a health chip that has all comprehensive health information, and then that will change the business model and structure and incentives, healthcare process and delivery structures that will create a more efficient value quality system. Your thoughts?
Oh, well, the fee-for-service for sure needs to be blown up because it's designed to treat disease, not create wellness. So I agree with that. As to the rest of it, it's an old story. So how does it actually happen? A lawyer by training, I represented banks, big insurance companies. The clearinghouse rules for banks, in other words, bank information, has been around since the latter part of the 19th century. Those little numbers on the bottom of your check. It's in the mutual best interest of banks to know those numbers. So they collaborate. It's called FISERV. All your checks go and get scanned and so forth. There is not a mutual self-interest among healthcare providers to coordinate the data because the fee-for-service drives us apart. The ACO is supposed to drive us together in doing that. So that's actually what I was supposed to talk about, was the ACOs, but I drifted off into this other stuff. And the purpose of the ACOs, Accountable Care Organization, is to knit together those things to do just what, and get rid of the fee-for-service incentive for the provider. Now, I made my living for 30 years billing by the hour. More was better. I got relentlessly measured on more was better. So you know what I did every morning when I arrived at work? That's fee-for-service, and that's not quality. That's a different thing. So I agree. I just don't know how it's going to happen until we invent the ACO, and we're busy working on that. I think I've exhausted them. There's somebody way in the back.
I want to ask you the question regarding what you ended with, which is the financing of the system. I still think it's not what we spend on healthcare, because we should spend whatever we want as long as it's our money within reason. It's that the way we finance healthcare has made the government's payment of it unsustainable.
Right, agreed.
So I just want, what's your solution from your perspective?
Well, are you the one that said patients need to have more skin in the game?
Yes.
Yeah, well, I agree with that. And I'm a firm believer in Freakonomics. I don't care if it's $30 or $300. If you've got such a trivial amount in the game, it won't make any difference. The difficulty is the access issue. I'll give you an example. I went to an autism conference this morning. Primary care physicians, there's now no longer any basically behavioral health is going away. So these are nurses from all over the state who work in autism with schools, and they said, here's what we're doing. They said, Mr. Evans, we're embarrassed to tell you this, but here's what we do today. We send autistic kids to your emergency rooms. So we got this barbell going on of responsible payment by some and irresponsible delivery of services by others to people who need the services anyway. So I don't know how those two talk to each other, except that the government reimbursement scheme is premised on the notion that they'll pay us less for us to charge you more, meaning they reimburse us at what we claim to be a number less than our costs, and so we shift the cost to the rest of society, but the number of commercially insured is shrinking, so that's the train wreck that's happening. And the Health Indiana plan, the one you alluded to, is a great success, and a week ago Friday, the CMS denied Indiana's waiver to use the Healthy Indiana plan as the plan compliant with the Affordable Care Act. I don't know if it's politics or they don't like success. I honestly don't know, but it's silly. I would encourage you all to read the article that's in the New Yorker recently on Camden, New Jersey. We all want to talk about ourselves like I just did, my brother, my mother, but my brother, my mother-in-law, and my wife are not the ones that are bankrupting the system, because they're not the high utilizers. Who's bankrupting the system are people that aren't part of a system, a family system. So Camden, New Jersey, the big hospital there, concluded that 66% of their patients came through the ER and didn't need to be there. So a local doctor there got so frustrated with his CEO, me, the guy who's me, because that guy was beds in heads, right? Heads in beds. That was a good thing to him, because he got paid Medicaid rates anyway. There were very few charity care cases. He got paid anyway. And Medicaid, despite what we say about it, is still cash. And the power company doesn't take vouchers, it will take cash. So when the Medicaid payments come to us, we pay the power company and all that kind of stuff. Well, in any event, he did a census block analysis on his own, not census tract, census block. And guess what? He found out the poor people that were using his services happen to live in the same places. And we run big box stores. And you come to big box stores. You don't take the big box stores. So there are some disciples of that in this room, and you know who I'm talking about, where the services have to go to the patients electronically, virtually, and really, and that will drive down the cost. They found one lady who lived in the same spot. How they got her address, I don't know. They assign addresses to homeless people, because this was a homeless lady who'd been to the big hospital in Camden in 1 year 375 times, so every day. Every day. The rules prevented them from admitting her because she didn't qualify under the algorithms for an overnight stay. So by the time the housing people would make arrangements for her, she would be released, and she was an alcoholic. So she was clever. So the hospital finally broke the rules, kept her overnight, ate that little tiny fee for which they weren't being reimbursed, so the housing people could get her placed in a community where she would be supported. She hasn't been back in 6 months. I was at the White House the other day with some of my colleagues, and I met the doctor who did the program in Camden. He's the one you should be talking to here, because he's dealing with the solution real time. And the solution real time is all those people I don't know that I need to somehow use information IT, biometrics, disease state management, community health, and get held accountable for that. So IU Health is right on the edge of measuring our success and reporting to our bosses, the IU Board of Trustees and the Methodist Church, community health. Have we made a difference in the communities we serve? We can see that we made a difference for the patients that we've served, but have we actually improved the culture of disease in a community? In other words, is the hemoglobin A1C in Tippecanoe County, the diabetes burden there, any better now than it was 10 years ago by virtue of any activity we've participated? You heard the Purdue engineer, they're helping us on that. So how do we do it? Because this is about a cultural change, not a one-off change. And we know that if 20% of the people start behaving in a different way, 80% will follow them. Somebody made the reference to Twitter. That's the proof of that. The diabetes control that somebody made a reference to. The coaches at IU communicate with the basketball members via text messaging. Not the coaches, the doctors do. I talked to a pediatrician in Cincinnati the other day who manages a population of pediatric diabetics. She communicates by text messaging with them with a copy to their whatever, their mom and whatever. She said they respond. Ontario Corporation in Muncie, Indiana, bills for hospitals in Sallie Mae. So they have real-time data about communication. Met with them the other day. Tony Rice, their CEO, great guy, says, you know, we're just old-fashioned, Dan. You send me a written letter, I read it. You send a written letter or an email to one of my 30-year-old kids, they never read it. It sits in the inbox or the mailbox. In fact, because of my wife's broken leg, she hasn't been getting the mail. That's her job, is to get the mail, because she actually cares about the mail, and the rest of us don't much care about what's in it. So you know where it is after a week. I asked last night, is the mail still in the mailbox? It's been in the mail. So we proved the hypothesis. So what he said, what Tony says, is you have to communicate with the customers in the way that will achieve results, not communicate with the customers in the way you're accustomed to communicating with the customers. So this is Peter Drucker, right? Seek first to understand, then be understood. And we don't operate that way because of the 18-minute rule. In 18 minutes, you can't seek to understand and then seek to be understood. So we've created an impossible situation. Here's my last comment. Cleaning out some stuff the other day, I found the 1972 report of the U.S. Chamber of Commerce on healthcare reform. It was chaired by Dan Searles, the commission, Dan Searles and Dan Evans Sr., my dad. I was in law school. Of course, I had no idea. It is not historical. You could take the date off of it, hand it to Aspen Institute, rebrand it, and pass it out in this meeting. It talks about electronical records, whatever those are. But it talks about coordinated care, and then it has a very complicated picture of how you would coordinate care of a cardiac patient. And the last page contains the dissents. Dissent number 2 is from Dan Evans Sr., the co-chair of the commission. I thought, oh God, what did Dad say? And what it says is, this won't work because it ignores actuarial science. The father of a baby boomer who ran a chain of department stores across the street knew that in 30 or 40 years, innovation and population would eat up whatever resources we had, and a little bit of coordinated care wasn't going to make any difference. The first appendix is a picture of the cost of health care in 1970 and in 1950. And it divides it by how much others pay and how much you pay. You know what I'm going to say. So it has a chart that goes like this. In 1950, 95% of health care costs were paid by you. In 1970, it was about 45%. Today, it's 10% are paid by you. So back to Freakonomics, how you get the customer involved. As P.G. O'Rourke said, you think health care is expensive now, wait till it's free. Thank you very much.
I really appreciate those comments because it was just absolutely extraordinary and added a real energy to our already energized group. We are going to go right into the next panel, and to do that, we're going to just take a few minutes to set up the cards, and then we'll proceed immediately because we're running a little bit behind, but we're going to make up that time.
And also oversee IHIT Incorporated, Indiana Health Information Technology, the state designated entity that is responsible for implementing the state HIE program here in the state. And so we've put together a panel today to talk about some of the HIT efforts that are going on here in the state. And you know, all the panelists and some of the speakers before us have talked about HIT being one of the critical building blocks for all the healthcare reform and other healthcare improvement activities going forward, regardless of which direction it goes. And so, you know, the panel members we have here today represent several of the key stakeholders here in the state that are you know, implementing and achieving and some of these tasks for health information technology. And so we hope to share with you some of the activities that are going on here in the state with discussion of how these apply, nationally in the future. And part of my role, I have the opportunity to travel around the state and also, travel throughout the nation and interact with other states and some of the federal folks that are in the HIT sector. And it's interesting when you start to hear the regard that Indiana is given with respect to health information technology. And a lot of that is, there's been many years of leadership by some of these stakeholders here in Indiana. And so to lead off, we're going to introduce the panel we have with us today. Dr. William Cast, who is the Chief Executive Officer of NoMoreClipboards.com, a personal health record company located in Fort Wayne, Indiana. We have Stan Crosley, the Director of the Indiana University Center for Law, Ethical, and Applied Research in Health Information, or otherwise known as CLEAR. Health Information Strategy Center created through IU's School of Law, Medicine, and Informatics. Chris Mickens is the Chief Technology and Compliance Officer for the State of Indiana Department of Health. She is responsible for the oversight and direction of the agency's IT infrastructure and directs the research and technology solutions at the State Department of Health. And then last, Tom Penno, the Chief Operating Officer at Indiana Health Information Exchange, the nation's largest health information exchange. And so kind of to lead off this discussion, I'd like to have each panel member kind of give an overview of some of the activities that your company or your organization is currently undertaking.
Live now. Can we be heard in the back? Is it working? Good, thank you. Well, No More Clipboard is a division of a larger company that began running a health information exchange up in northeastern Indiana, which would be medical informatics. We do the personal health records, but the platform works as one, and so we're able to serve a lot of niches in healthcare. I'd make a broad statement by saying that Indiana is indeed known to be a healthcare information technology leader. I think we're well on the way to becoming the leader in patient engagement as well, and that is a big step. Our company uses a SaaS platform, a web-based, cloud-based platform. In the state of Indiana, we serve Indiana University in the student health, and we serve IU Health. We serve Eli Lilly in the state. We serve Disney around the world. We serve the Google clinics, at least for now. We're working in New Jersey with the Meridian Health System. We work with Dow Chemical around the world with their clinics, and really many, many more, a lot of industrial health. And the reason is we could start with everyone, and we tried that, and we failed to get healthy people to use our product. But people who have a purpose, workers moving from an oil field to oil field with no health record, students going to a clinic, diabetics that you don't want to be admitted. For example, in Washington, D.C., with Richard Katz at George Washington University and at Howard University, they take care of homeless people on the street, coordinated with No More Clipboard and cell phones. And an admission is $21,000, and treating them in the van is $1,500 a year. So using Pareto's law, using the 80-20 rule, you would take care of the high expenditures and the high users first, knowing that your product would serve a broader group. So I'll quit with that, just saying that we're in chronic disease management, we're in industrial health, we're in rehabilitation, we are in patient engagement, and our last big convention, I think, was in San Francisco 2 weeks ago at Health 2.0, and that would be the epicenter of the patient-centered care movement. The whole convention, 1,500 people, were there to talk about patient-centric care, and the fact is, if the patient's going to be at the center, they're going to have to be digitally at the center as well. They're going to have bidirectional digital communication with all the other providers, and we are in that space as well. So.
Thank you. Those are fascinating comments, because I think they do dovetail a little bit of what we're doing at IU. The Center for Law Ethics and Applied Research in Health Information, or CLEAR, as Andy pointed out for us, is really kind of has a mission to free up the use of health information, in essence helping to try and clear away some of the regulatory underbrush. A couple of projects we're working on right now, one of them is with Regan Streif, and we are in a project looking at the PCAST report that came out from the President's Committee on Advisory and Science and Technology Committee, PCAST. That came out and made the recommendation that patients could potentially have more granular control of their health information, and by doing this, it would actually help the system to have a better uptake and better utilization of health information technology, et cetera, claiming that privacy is one of those issues. And we're kind of teasing our way through that report, looking at the practicality of metadata and the utilization of more granular control by patients. Inherently there's some issues, and I'll comment on those a little bit later with control, but that's one project we're exploring. The other one another one we're working on is we believe that there is more health information getting generated every day outside of the healthcare system than inside of it. I think that's probably logical if you sit back and you think about it. Everybody has an iPhone. There's a cholesterol app or a heart rate app, or your tennis shoes can certainly tell your heart rate when you run now. The health information is getting generated at enormous rates. Insulin pump manufacturers like Medtronic, they are getting hundreds of millions of data points every day from hundreds of thousands of diabetics that is being auto-uploaded into manufacturer sites sitting in the cloud, completely outside of the control of any of the regulations. The danger here is that people are going to start figuring out an efficient way to utilize that data to help their health care. And so we're building an interstate system that, if we're not careful, may not have many cars on it because the ease of access and utilization of information outside of the healthcare frame is much easier than utilization of the information that's inside of it. Obviously, the quality of the data is a major concern, but it's getting better. And so one of the projects that we're looking at is, in fact, utilization of this data that's created outside of healthcare. How can you incorporate that into electronic medical records, health information technology in general? And what's the standard of care that needs to be used? What are the ethical issues, the regulatory issues to utilizing this type of data? And what are the types of projects that we can put together to perhaps attract researchers if you have a cohort of patients and their families with a chronic illness that are willing to give genetic information, epidemiological data, as well as importing electronic medical records into a PHR. What are the barriers to doing that? So we're kind of looking more holistically at this system and trying to figure out what the barriers are to that data flow.
Good afternoon. One thing I can say at the Department of Health, we understood our challenges when we first started down the journey of looking at how to better capture the data that is mandatory required to be reported to the Department of Health, and then how we begin to utilize that data. So one thing we had identified as one of our key factors is how to consolidate and streamline the interfaces that we have with a number of our external partners in the healthcare industry on the reporting of that information. Then also look at standardizing the interfaces and how that information is utilized. So some of the key projects that we have underway right now is for the expansion of the immunization data that is reported to the state's immunization registry, CHIRP. We are looking at partnering with a number of our partners that are also partnering with us. I would say our Health Information Exchange, some of our EMR vendors, to make sure that their products that they're offering to even the hospitals and the private practices already have interfaces in place so that data will flow smoothly. And then also working with the hospitals so that we can begin to streamline the interfaces on them sending data to the Department of Health. And then not only that we are receiving that data, because we are mandated to report the current immunization status to CDC, but also that we are able to submit that data and provide that data back to the entities that are sending us data, more for bi-directional feeds. So we have probably, I would say, 10 to 20 bi-directional feeds in production right now where we're able to share that information back with them so they can utilize that in providing care and treatment for the clients that are coming into their facilities to receive treatment, to ensure that they're not immunized and they're not receiving multiple immunizations that may have been received at another provider location, but it's not documented and they don't have access to that information when the child is presented to them for care. The other area we're looking at is in our surveillance unit. We're also looking at adopting, and we have adopted, some of the industry standards for the transmission and reporting of surveillance data. Currently, right now, out of the 122 hospitals in the state of Indiana that have emergency room facilities, we have 110 that we are currently receiving 24/7 reporting on the chief complaint when individuals come into emergency rooms. We use that data for our surveillance activities so that we can quickly identify if there's any type of outbreaks within anywhere in the state of Indiana, whether it's respiratory or for any other reason. So we can immediately get on top of those and work hand in hand with individuals at the community levels, even with CDC, to address those issues as quickly as possible. The other area we're looking at continuing to expand upon is our electronic lab reporting. We have so many areas within the Department of Health that depend upon immediate outcomes as far as lab results and test results in our HIV area, in our cancer registry, in our TB area that are critical for the outcomes of lab reporting. So we are trying to expand upon the laboratories that are reporting. We're trying to encourage them to report in the national standard for laboratory reporting so we could better utilize that data. And again, you know, we don't just want to become the house for where all this data is submitted and we are just using it internally to assist us in better decision making, but also that we can disseminate that data back to our partners in the healthcare community so they can utilize that. So we can provide the data back to the providers that are at the area of providing care, and they can use that information to assist them in improving the quality of care that the patients in the state of Indiana are receiving. So one thing that we understood early on is that we cannot do this by ourselves. And we have been very fortunate to partner with a number of what I consider trailblazers in collecting and receiving and reporting of information. We realized this, I would say, 10 to 15 years ago, and we entered into a partnership with Registry to assist us in the capturing and reporting of data electronically. So we have continued those partnerships. We realize that we are now having to expand those relationships, working with even insurance companies, WellPoint to be one that we're currently working with to see how we can create a partnership or relationship for also utilizing claims data to assist us in having a fuller picture, a more complete picture of really what the healthcare status is for the citizens in the state of Indiana. So we have realized that it really requires the partnership, the collaboration with working with everyone within the healthcare industry to really improve upon the quality of care and the delivery of care, and at the same time to try to be able to control the cost of what the healthcare delivery system is in place today.
Thanks for having me today. As I thought about your opening comments, Indiana Health Information Exchange is here today because of one of your premises was a value-based leadership. And some of the leaders that we have here, and you heard one of them, Dan Evans, sits on our board, was a real visionary when it came to creating Indiana Health Information Exchange about 8 years ago. We work very closely. You've heard everybody, I think, almost mention Reagan Street Institute. They've been around for 40 years, and they're really the preeminent medical informatics research institute in the country. So there's been a lot of innovation that comes out of there, continues to come out of there. So right now what we do is Indiana Health Information Exchange, we're focused primarily on 3 services. One is a clinical messaging system that 8-10 years ago it seemed pretty innovative, and A lot of people are catching up with us, and it's almost becoming kind of a commodity. But the basic principle is that you go to your doctor's office, they pull a blood sample, it gets sent out to the lab, and that result can then be sent electronically back to the physician. And in fact, now it can flow straight into their electronic medical record. And while it sounds pretty simple, it saved the hospitals a lot of money that they didn't have to mail or courier or fax these results out. We have expanded that system to, we probably send out about 7 million messages a month now to over 20,000 physicians across the Indiana and Chicago border as well. So it's pretty impressive system. I tie that to the INPC, which is the Indiana Network for Patient Care, because a lot of the underlying infrastructure is involved with that, and some of the things that Chris mentioned as well, the surveillance stuff can flow into the INPC. And the basic concept is, the idea is you go into emergency department and all the participating hospitals send their data into the repository. You get checked in, and the minute you get admitted, it queries the system and prints out an abstract of everything it can find across all the systems. And the emergency physician can review that. So they'll have information in there about the pharmaceuticals you've been prescribed, so it's a very beneficial system. It's now expanded into inpatient, and now we're starting to work it out into ambulatory. And the whole idea is that a hospital system only has the information they have on that patient. And it's been proven, there's a recent study that Reagan Street did several months ago that shows patients travel through all the different systems. They don't really focus in one system. So there's bits and pieces of their care across that whole continuum. So the INPC is something that got started probably 15, 17 years ago, and it really was a key component as each one of the hospital systems got involved with it. It created the trust, the data use agreements on how it could be used, how the data could be used, and it really took that long for the whole thing to come together. And it was once all 5 systems were involved with it, that's when they said, listen, let's create iHigh to roll out this clinical messaging system. The third service I want to tell you about is something we created several years ago called Quality Health First. And the idea was that, you heard Marcus talk a little bit earlier about claims data, and you think about the INPC, it's filled with real-time clinical data. And if you start to combine those two together, you can get a pretty good snapshot of a patient's care and who their providers are. And so the idea was we went back and looked at some very basic measures that the physicians would buy in on, like A1C levels for diabetics, et cetera, mammograms, colonoscopies. And so we then put out a monthly report to physicians, mostly primary care at this point, that gives them an indication, these are let's say your 1,000 patients, and out of that 1,000, we think 100 of them are diabetic because we see an A1C that's greater than 8, or a diagnosis code, or they're on a prescription for something diabetes related. And out of that 100, only half of them had their A1C done in the last 6 months, which is best practice. So you should get them in and be preventive and get that A1C test. So there were a whole lot of great stories. We're still working on the RI, but there's a whole lot of great stories that came out of that. Particularly, there's one story about a physician group on the south side that decided, well, we're going to focus on colonoscopies. So in these monthly reports, we send out alerts and reminders, say, hey, these 12 patients need to get their colonoscopy done. And this one physician group decided they were going to focus on that, and they found like 6 or 7 patients who they probably would normally have not gotten a colonoscopy done, but they're in precancerous stage. And so you start to hear stories like that, and now we just have to figure out how to wrap it around an ROI. But so the Quality Health First program is something that's pretty innovative. It's real challenging, and you heard some of the challenges when Marcus talked about just claims data versus clinical data. So I tied together to the piece that we were fortunate to get one of the high-tech awards, Beacon Community Awards, a year and a half ago. And the Beacon Award is basically the idea that came from ONC was that, listen, there's some communities out there doing some pretty neat things. And what if we just threw some money at them so they could do it faster? That's kind of paraphrasing, but that's the way I looked at it. We were on the path of expanding across the state anyway. We were expanding clinical messaging, we were expanding the INPC, and we were expanding Quality Health First. And so the Beacon Award is really just that. It's additional capital for us to grow faster, and that's how we're utilizing it right now. So that's what we're up to.
So, Tom, you mentioned ROI. I guess for both you and Bill, representing organizations that are out selling products and services, where does sustainability fit within your strategies, and how do you try to address that?
It's a great question. One of the things I loved about when the Beacon funding opportunity announcement came out, there was a whole section in it focused on sustainability. And that's the heart and soul of what we try to do. As we roll out a service, that service has to be wrapped around what we think the sustainability model is. With clinical messaging, the idea, and I kind of alluded to this, the idea was that within a hospital system, we estimated they were spending probably 80 cents to send a clinical result. And by utilizing this system, we were going to be charging them in the neighborhood of 15 to 17 cents. And so it was a huge win for the hospitals. And it's ironic because that cost of 80 cents to them before was spread in so many budgets, it was nobody's one line item. Well, we started doing this, and now it was the CIO's line item. And across the board, they all underestimated their volume, and we were doing it as a transaction model at that point. So it was a huge win, but it was like, what have you done for me lately? Now what's the next thing? With the INPC, we just rolled out a sustainability model around that. And the idea is the hospitals and labs and radiology centers pay us to have access to that data. When I say access, we have a pretty strong group called the INPC Management Committee that's made up of, I call it the conscience of the repository. And they decide, and they're all participants of the INPC, they decide how that data is going to be used. And when I made reference to the 15 years of building the INPC and the data use agreements and the trust, it's really that conscience that determines who can access it. But with the INPC, so the hospitals now pay us a fee, and it's a flat rate fee, and we've actually gone away from a transaction model for clinical messaging to a flat rate fee as well for that. So there's those two pieces of some of the sustainability. The Quality Health First piece is a model where the payers pay us to be that independent aggregator of the reports. One of the things I didn't mention was every quarter we do reports for the participating payers on how the doctors are doing on their measures. And the payers, by contract with us, agree to incent the providers that they make improvements in their measures. So, and we have WellPoint involved with it, United's involved with it, and then some smaller TPAs. But that one's still a challenge for us to get it sustainable, but without question, that's something that has to be a much broader footprint in the state of Indiana before it'll be sustainable. So.
For No More Clipboard, we were pretty much forced into a role of being in a niche because each one had to be profitable enough. We've had no venture capital around. We've paid for the company out of profits. So if I went one by one, I'd say that in doing an industrial clinic with a big company like Dow Chemical, a lot of their motivation is they will pay for the service because of compliance. They're complying with OSHA, they're complying with FDA in the case of a pharmaceutical company, and coordinating their care and coordinating their data makes sense to them from the standpoint of regulatory compliance and health savings. In terms of a university, the students can register with their health record because their vaccinations and all their health care is in there, and you will save money by not having as many people at the front desk in your health clinic because all the student records and their history and their appointments are all sent by the portal and the health record to the clinic, so you end up with efficiency savings. In the case of a university, if you run a clinic and you coordinate care and you coordinate your high users, because probably 15 to 20% of the people spend 80% of the money within the system, if you can coordinate that care and you will organize it in a chronic disease management where you avoid readmissions, you avoid admissions, you get better care, you control the A1C, you can then charge less with your health care benefit. You can drive the insurance product by coordinating the care. If you don't want your care coordinated, then you can pay market. If you want your care coordinated, you can pay less. And in the case of something like volunteers in medicine, the same thing is true, where we would be working with a homeless or a very stressed clientele. By coordinating everybody digitally, you can make more efficient use of your resources, and you can get people into group therapy, group clinics, group care, and there's where your savings will come, even with things such as smoking cessation or substance abuse. The more you communicate, the more you can get people to communicate within the group. That's where your pay has to come. So eventually, when everybody can communicate with everybody's electronic record and hospital record, there would be a market for a general product where healthy people would have this. But as it is now, you have to look at the sustainable model and the income from the model in order to grow. And there's plenty of opportunity, lots of opportunity.
So Stan and Chris, what do you see as some of the barriers going forward that have to be addressed both locally and nationally in order for us to kind of achieve the outcomes and goals that have been set forth?
Well, I think what we're seeing as we continue to work with some of our partners around the state is some of the laboratories that we're trying to encourage them to adopt some type of electronic capability to report to us electronically versus sending us in faxes or still in some cases even paper through snail mail. So what I'm seeing is the laboratories are really not embracing any type of standardization, one from a financial standpoint to some of the barriers that they're incurring, and also, so we're not getting the emergence of laboratories coming to us wanting to submit electronically because, one, they don't have the capability. We're still running into a number of mom and pop shop laboratories that do not have the financial means to submit to us electronically. I would say that would be one of the barriers. The other barrier that we're even seeing in some of the private practice facilities as far as submitting to us immunization data is for some of the smaller provider practices. There is, I guess, a lack of education about all of the resources that are available and even some of the financial incentives that are available for them to adopt electronic medical records. So it's just the complete adoption of electronic medical record systems that will assist us in the facilitation and the sharing of data electronically, and maybe some of the financial assistance for some of the laboratories to assist them in embracing the electronic reporting.
And we have the luxury at CLEAR to kind of sit back and let Bill and Chris and Tom figure out the technology aspects, and we're confident that with Andy's help they're going to do that in Indiana. But what we look at is that we're fearful that even once these things are built, there's going to be significant barriers that are going to be placed in the way. I've likened this before to having an interstate highway with a stop sign every 50 feet. And those stop signs right now are the idea of privacy. It's the potential for liability, and it is potentially ethical or even intellectual property issues that we see kind of circling around this entire network. First on the privacy, and I intentionally said the idea of privacy because privacy itself is, of course, incredibly important here, and having the trust of patients is important. But the way that the regulations are going about this is really very misinformed and unfortunate. Every state, all 50 states, have dozens of laws that restrict the use of health information. These are data restriction laws more than they are privacy laws. HIPAA is an incredibly bureaucratic system that requires lots of paper. The notice that you receive every time you go to the doctor's office, I doubt very seriously whether you've read it. I haven't read them, and I wrote most of them and for my clients. It is and they're required by law. They're strictly set up, and you have to have certain criteria involved with them. And they're not consent documents. They simply give you notice because HIPAA breaks this down into different ways you can use data and what you can and can't use it for. One of the ironies is one of the very few things you still need consent from patients for a disclosure of health information is for research. You have broad rights to disclose as a healthcare provider to a policeman off the street if you think that it's a valid law enforcement request. HIPAA says, go ahead, give them the entire health record. If you have a researcher stop by and say, I'd really like to do research here, wait, no, sorry, we cannot disclose that to you. You have similar barriers that now, with all 50 states, there are hundreds of privacy laws. And we've done the analysis. We have charts that we've been creating here. We're going to make them public hopefully in the first quarter of next year that have tracked these laws and done some assessment on these things. There are hundreds of privacy laws. So even if you figure out HIPAA at the federal level and you figure out Part 2 regulations and substance abuse and things like that that allow you to move these this data between healthcare providers, you've got state laws to tackle. Genetic information laws and the genetic privacy laws extend to the point where there are personal property rights and genetic information granted in 5 states in the U.S. now. Alaska gives a personal property right in the tissue itself. And so the barriers that are being put up here in the understanding that we're going to protect privacy are very unfortunate. And the reason why I say it's the idea of privacy, if you talk with chronically ill patients, and you heard Bill talk about this is where the system is moving faster than anywhere. They have the need, they have the desire to adopt these systems. If you talk to chronically ill patients, and we do all the time, there's a group called C-Change, which is one of the largest national organizations for cancer patients and their families, as well as the National Institutes of Health, who has done studies on this. Chronically ill patients have privacy about 10th on the list. They certainly have care and treatment, coordination of care, coordination of their specialists, but research also very high on this list. If you talk to these patients, they will say, well, we assume that if you have our data, that you're also using it for research to help the science. They're shocked to learn that that's not the case. And now with the new proposals coming in for the advance notice of proposed rulemaking for human research, that could be even more problematic from a research setting. So the unfortunate thing here is there is no harmonization among these states on privacy laws. They all have their own mini HIPAA in addition to the federal law. You also have the specter of liability. The Sentinel Network, I'm not sure if you're familiar with this, the Sentinel Network is an initiative by the Food and Drug Administration where they are going to try and have a surveillance network for adverse events for drug products. The way they are doing this, they've gotten volunteer organizations such as Kaiser, the VA, and others to agree to take their record sets, put them through a common algorithm to create a common record set that can then be searched with an algorithm that's created by the FDA to assess or verify adverse event reports, to try and do signal verification or validation. Hundreds of millions of patient records will soon be available through this system. One of their biggest issues they have to address is if it's in a system, it is also discoverable for purposes of litigation. And so as plaintiffs' attorneys become aware of this, and they can do an instant standard of care analysis across a record set to try and determine that there is a physician who is out of step with that standard, and then use that in court. And so broad subpoena rights already exist in HIPAA, and those records have to get turned over. And so as you string these records together and this data together, the billions of dollars that are involved in product liability or physician liability and litigation are going to be funneled toward this piece. And this is a policy that has got to be taken on and has got to be addressed. Or even if the system is successful and launches, it could have some fairly significant barriers down the road.
What questions, I guess we'll open it up. I have other questions I can ask, but what questions are out there in the audience?
Thank you. Peggy Welch from Bloomington. Serve as a legislator, and I was talking with Mr. Evans when he was leaving, and we were talking about coordination of all the health exchange programs, and that he suggested that Indiana kind of has missed the boat, that other states have coordinated better, and because we're not able to interrelate, and I'm not using all the right terms, but can you talk to me more about that, and is there something that the legislature should be doing to encourage more of being able to be coordinated?
I'll take a stab at that. So I would offer up that Indiana has been so far ahead of the curve that the various health information exchanges that have developed, one in South Bend, up in Fort Wayne, Indianapolis, Bloomington, and then down by Cincinnati Health Bridge, have all been developed with private dollars. There has been no really government push to do it. And along with that, as the government started to push to do it, I mean, and frankly, Andy had a challenge when he had to finish his request for funding for IHIT. They didn't think it was good enough. We're different enough from the other 49 states. They wanted to see something very different. It's been a challenge, but it's because we're that far ahead. We're that more innovative, I guess I could say. Certainly with the other HIEs, there's a bit of a, candidly, politics. You know, we all want to grow to be bigger, and so there's a challenge there. But under Andy's leadership and IHIT, we're working and have been working actually for 2.5 years now. We've been meeting routinely, pre-Andy, to figure out how to get them interoperable. I mean, iHi is now connected to HealthBridge for clinical messaging pieces. We're now in the process of trying to get one of their hospitals to flow into the INPC. We're in the process of developing with Michiana Health Information Network up in South Bend that same connectivity as well. So it's one of those things, it's coming, but we were just so far ahead of the curve. We're a very different model than the other 49 states. Do you want to add?
Yeah, and I could say, you know, from the state HIE perspective, I mean, we've set aside $5 million specifically for driving interoperability with the private sector organizations. Other states are taking much more of a public utility model as far as that it's being built centrally at the state level, and it's currently being funded by the federal stimulus dollars that were set aside, and eventually will be probably supported by the taxpayers in that state if there's not enough funds brought in by the private sector. And so Indiana's approach has been to partner with the private sector organizations and to really keep the innovation at that grassroots level, rather than at the state and centralized control approach.
I want to add one other thing. Dan has sat on our board from the get-go and always made the analogy to the utilities. In a lot of ways, I think there's strong potential for an HIE to become just that, a utility. And what's going to differentiate the HIE in this world of ACOs, accountable care organizations, is the ability to use all that data. You have Hospital A with, you know, they have 100% of their own data, but only 20% of the data on that patient. That HIE has the opportunity through innovation to supply more reports back, analytics around that will help support the ACO effort. So.
Go ahead.
You're up.
I was going to say, I was going to shift it a little bit to policy, so if you want to follow on.
Well, if I were to comment on northeastern Indiana, my parent company operates the HIE for northeastern Indiana, and we very willingly cooperate with iHi and would exit the business if there is a way to integrate. Funding is a problem in that the clients that are now supporting it, the hospitals and physicians that pay a millage on the transmission of data, are beginning to look at the cost and looking at the lowest cost way to do that. And so that's not a very efficient way to build a system if everybody begins to look at their own dollar. I think that what you have heard up here is exactly right. We're working our way through a unifying of a system that has grown up from the grassroots. And part of our problem is that we are so far ahead of everybody else, and that would include Massachusetts, who they can communicate from Boston over to Springfield, but they're not statewide. We really have a very robust system. It's just not all the same.
What I would add from a policy perspective is that there has not been a state legislature yet in the United States that has taken on the issues that are really underlying this network that are going to be policy-based. And so you think about liability, physician liability. I think that Indiana could be in a good position to try and suggest a framework that may work on a liability perspective. You know, the vaccine compensation fund comes to mind, right? If harm occurs and it's observable, and then compensation is applied for and received. But absent something like that and the ability of broad access and unmitigated liability to exist, I'm very fearful. We're very fearful, clear that in fact this system could have a collapse. Similarly, no state legislature has really looked at the privacy or the data controls or the data use from a patient perspective or from a research perspective. Tom mentioned that the INPC has a conscience board who looks at the appropriate use of that information. That is a phenomenal approach. I mean, that is a brilliant approach to how you want to use this data. They can do that because they put an enormous amount of blood, sweat, and effort into getting that data there through data use agreements that are not easy to negotiate across multiple parties. It's not scalable. You cannot scale what they did and say it's going to be a national network for sure. It's hard enough to scale it for Central Indiana. And so if you can take that concept of what's the appropriate use of that information and agree that there's a standard here that should be enabled, and then put policy around that and some regulation around that, I think you would have a utilization of information model that could be exportable to every state. And that's really what we need.
Other questions? Back?
I get two microphones. Whether what's being spent and what is developed has any, to be blunt about it, utility, in the sense that I really don't care if I'm a doctor or a patient, whether if I live in New Jersey, which I do, I can access my medical records in a hospital or clinic in San Francisco. I'm more concerned about whether I have information at point of care that's actionable and information that will improve my decision, and then information after the event that will allow me to improve my care going forward. And finally, do I have information that will allow me on a prospective basis to stay healthy? And it sounds like all the barriers that you face are A, speak to an entity that doesn't address that, and B, make it difficult to achieve what I would think would be the utility for health information going forward.
I'll tell you a story. When I came on board here, I heard a story about how the 5 CEOs sat down and said, you know what, this is the right thing to do for Central Indiana to share information. So there was no legislature, there was no policy. It was the 5 of them sitting down to say, this is the right thing to do. I had a chance to hear them have that same conversation in October, and it made me very proud to be somebody living in this community as well as working with IHIE, because you don't see that in a lot of other communities. And Andy and I were talking a little bit earlier about the challenge even to get that next hospital to commit to share the data. There is no policy to do it right now. And I don't know that you can mandate it. At some point, I think you have to, I suppose, because it's the right thing to do for patient care. And if you can address, as Stan said, all these issues about the data use and the get everybody comfortable with that, you could probably get there. But it took a long time and a lot of trust had to get developed before it was successful here.
Well, I don't want to answer a question you didn't ask. I'm going to try to. I'm going to try to address what you said. I think. First of all, a personal health record. We're not an electronic filing cabinet. We're a platform. The patient has a digital platform. Secondly, there's several workarounds. For one comment earlier about being digital, we're fax interactive so that the TIFF file coming out of a fax machine becomes digital within our system. So you can fax in and out of our system. Thirdly, we have a workaround on the internet. We have a URL called CC.me. If you will have any hospital that is digital, any provider that is digital, send it to the CCMe account / your name, we will populate your health record for you through CCMe. So we have that workaround. Also, we're inside of HIPAA, or actually we're outside of HIPAA. You own your health record, and you can send it to the New York Times if you want to, because it is yours. And so once you own it, and you operate it, and you send it, and you're responsible for populating it, it will go anywhere in the world. So to the degree that you put in your imaging, because we can arrange to show the images inside of our platform, and the records, and the reports, but mainly, I think, as the first contact physician, you want to know allergies, current med list, and I don't want to know the 82 instances of amoxicillin, and I really don't necessarily need to know why your grandfather died, although it can be in there, but there should be a decent reduction, a redacted short record for you that is valuable to the first treating physician. So I probably didn't quite answer it, but we're trying.
I want to add one thing about the high-tech funding. No More Clipboard got one of the challenge grants to focus on the PHR, and we're going to be working with them on that. And actually, one of the first steps we have to do is go to that INPC management committee and have that discussion. Hey, we want to test drive populating a PHR, and these are some of the challenges we face. So.
Well, to kind of wrap up and close, overall, there's been significant amount of spending, both from the private sector as well as the governmental side within health information technology. Indiana has received nearly $100 million in high-tech funding, along with other research funding in the area of HIT. We're estimating roughly there will be hundreds of millions of dollars of incentive dollars flowing into hospitals and providers to implement electronic medical records here over the next several years. But we are just scratching the surface in what it's going to take to really expand health information technology to where it needs to go in the future. And so, we're far down the road compared to many others, but we've just really started this journey. So thank you. Join me in thanking the panel members for their time and effort.
We're going to take another 15-minute break, and then we'll be back here at 2:30, I believe, and then we will have our last panel. Thank you. And I'm going to introduce Kristen Jones, and she's going to be our moderator who will moderate this last panel, and we will have time for questions. And Kristen is the president and CEO of Indiana Health Industry Forum. The forum maintains the membership of over 100 of Indiana's health and life science leaders. She also worked for over 2.5 years as the forum's vice president. She previously served as the director of business development, life sciences, and international affairs for the Indy Partnership. Additionally, Kristen spent almost 10 years with the Indiana Department of Commerce, serving as the director of the Office of International Trade. And I give you Kristen.
Thank you very much. Thank you very much. Good afternoon, everybody. Everybody all wide awake and ready to go for the final panel of the afternoon? We're all set. Okay. I think you are in for a real treat today because we are, I think this is a really marvelous way to end the session and really tie everything together. So I think this is going to be really good. Fran Marie mentioned I'm with the Indiana Health Industry Forum. We are a not-for-profit organization that's been around since 1994, and we are essentially a chamber of commerce for the health and life science industry. We do dabble in advocacy and public affairs and policy, and particularly around the theme of innovation and how do we allow our members to invest in that, conduct it, and recoup something out of that effort. So anything that ties into that and a policy framework is something that we're interested in and support and want to explore a little bit more. Over 12 years ago, our organization conducted or put forth a roadmap for a path forward for the health industry here in the state of Indiana. And I just want to read a little bit of that to you. The vision for the document was to position Indiana as a recognized center of economic vitality and innovation for health-related businesses and industry, globally competitive and attractive to business development interest. The goals and objectives of that were to increase the level of innovation and capture for Indiana-established firms, increase the speed of commercialization of technology to marketable products, build a less risk-averse, more entrepreneurial-driven culture for individuals as well as institutions, increase communications, awareness, and knowledge of Indiana resources among businesses and industry, and finally, increase risk capital essential to the growth of the health industry. It set forth about 8 different strategies for how we might go about accomplishing that. And here we are 12 years later, and we are starting to look back at that document and saying, gee, it's time to probably update that. But what we're finding through the initial survey is there's a lot of sentiment out there that we haven't really finished those original objectives, and we need to keep working on that. And hearkening back to Dan Evans' comments over the luncheon when he referred to the 1972 report on healthcare reform, you could just take it off the shelf and probably put it right back out there and change the font a little bit, and it would probably still be a very viable document. And I think we're looking at probably the same thing here. I'm not sure what that means for job security, but we'll go forward with that anyway there. I think the point in dredging all of this up is that for a long time now, health and industry leaders in the life science industry have been emphasizing the ties between innovation and economic growth here in the state. And it's something that seems to maybe not always make the connection in people's minds for some reason. Innovation is frequently something that is overlooked, underappreciated, and perhaps undermined when it comes to policy efforts in some cases, the final impacts there. I want to quote an article from a 2006 article in the Scientist magazine that was written by Melvin Billingsley and Michelle Washko, and it says, clearly that state and federal governments must work together to develop coherent policies that simultaneously use scarce funding resources wisely, promote better health outcomes, and encourage economic development. So this was written well before healthcare reform came into the picture, well before economic collapse and disaster struck us. So this is a little bit of an ongoing theme we're going to keep exploring here today. So what's a poor legislator to do in all of that? Our program goal today is to give you a sense of the important role state legislators play in balancing the need to manage state and federal health cost with the need to foster an environment that supports continued and increased innovation in healthcare and life sciences. And with that, please join me in welcoming our panel today. I will go through and introduce everyone real quickly. I think you have all their bios out there. Starting here on my right, Representative Peggy Welch from Bloomington area, serves on the House Ways and Means Committee, the House Health Committee, and the State Budget Committee. So very well-rounded and very experienced in all these matters. Sitting next to her, we have Dr. Tim Brown, who is state representative from the Montgomery Park and Tippecanoe counties area. He is chairman of the Public Health Committee. Next to him, we have Senator Jean Breaux, who is a former colleague of mine from the Department of Commerce days. She is a ranking minority member of the Senate Health and Provider Services Committee. And on the end, we have Senator Patricia Miller, who is a nurse, and also chairs the Senate Committee on Health and Provider Services. So with that, welcome. I think I will start off with sort of the broad picture question in that case. And if everyone would like to just sort of tell us what you think the role of a legislator is, or what the role of legislation may be in fostering clinical and medical innovation for this.
Thank you, and I appreciate being here. I also am a nurse. It was ironic. I was sitting in the back and got a text from my supervisor saying, "Can you work Sunday night?" And as Dan Evans was leaving, he said, "What are you doing here? You're supposed to be at work," because he is my boss, because I work at IU Health Bloomington. So I'm glad to be here with you. I love doing forums like this because it makes me sit and spend some time to really think about issues and brings me up to speed on kind of what I need to be thinking about and doing as a legislator. So I'm going to hit some things real fast. First of all, there's not much that we can do federally. But in talking with folks and in the reading that I have done and work that I'm doing in other areas, the word that you hear over and over and over again, whether it's the economy, whether it's politics, whether it's healthcare, or whether it's what you need to do with the FDA, is uncertain. There's so much uncertainty out there affecting our lives. There's not a lot that we can do to affect the feds, but there are some things that we can do here in the state. And I'm going to hit just some highlights, and I'm almost embarrassed to list them because they really are obvious, but it might spark some conversation for us up here and then for you out there. I really do believe a state needs to have a vision, have some kind of strategic plan as to how we're going to deal with the life sciences and how we're going to promote it within our state. There's some very successful stories across the country, and I think that we're generally doing a pretty good job here in the state, but we are lacking. So what are some of those things that we've got to look at? Obviously, K through 12 education and higher education. With K through 12, STEM education, really looking at the sciences and technology and engineering and math. I was reading just recently the article that was in Bio entitled Bioscience Education Study Finds Some States Lagging. Unfortunately, Indiana's kind of in the middle. My home state of Mississippi is way at the bottom, but there's so much more that we could do K through 12 to be able to prepare our students to be able to step up and be able to work in the life sciences. Also in higher education, we've got to maintain our commitment to quality and excellence. That means we've got to put the funding there to be able to help them to be successful and not be afraid of mission differentiation. I live in Bloomington. We have Indiana University, which is one of our top research institutions in the state, and then obviously Purdue and so many others. But we've got to make sure that it's okay to say, go be excellent, we will support you. Because you are producing a lot of the innovations that then go from the bench to the marketplace. I got my degree in Mississippi in education, but my nursing degree is from Ivy Tech, and I'm very proud to be an Ivy Tech community college graduate. And we've got to be able to continue to be supportive of our community colleges because they are the ones that are helping develop the workforce. So we really have got to say in this state, it's okay to say, go be excellent and do great work as a research institution, but also we've got to develop the workforce. Just recently, I was at Ball State, and they have a wonderful entrepreneur program there. And one of the things that they're working on is called the Military to Market Program. And it was real interesting. What made me think about it is they're taking patents and ideas of things that are being done at Crane Military Base. Many folks don't realize that we have a Navy base in the middle of the cornfields down in southern Indiana. And they have thousands of patents down there for all kinds of things. But one of the things they have a patent on, they've developed a material that is most like skin. Now, the reason they're developed it was because they have to shoot guns at it, bullets, and to see how, a bullet affects the skin. But one of the entrepreneurial students is saying, how can we take that and maybe use it to teach doctors and nurses how to do suturing on that? There's all kinds of patents out there and things that are being developed in our universities that we need to encourage as legislators to be able to be translated into the marketplace. We need your help, though, to know how we can help you do that. We need to invest in our infrastructure. I was just visiting with someone with a life sciences large organization, and she was saying that we've really got to have strong infrastructure because what they do is they fly out, thousands and tons of material to build products here in the state, and then they ship those materials or those machines that they make out to other parts of the world. We've got to have strong infrastructure, whether it's through trucking or through the airport. I'm looking forward to going to a meeting on Friday in Martinsville to hear the president of the airport authority, and he's got this vision for an airtropolis, I think is what he's calling it, to be a real driver of economic development, but that's going to help our life sciences program to be able to have the best transportation. So something to think about. We need to have appropriate regulations and controls. In Indiana, we've not gone the way of many states in kind of overstepping our bounds and also providing uncertainty. And so what I ask you, and those are the experts, and Kristen, we were at something together last year, something similar to this, and one of my questions was, tell us what we have to do as the state to get out of the way. Not just what do we need to do proactively to help you, but maybe what do we've got to do to step away to help you be successful? That's the kind of input that we need. I do serve on the Ways and Means Committee and the Budget Committee. Something we need to be thinking about is how we provide that, again, stable, predictable, and supportive tax environment. We do have research tax credits in the state of Indiana, and I know those are used heavily, especially by our larger organizations. We need to be looking at what we can do more with venture capital to help our startups. We have our 21st Century program here in the state of Indiana, which we continue to tweak and also defund in many ways. There's I think of many businesses that we have in the Bloomington area, but one specifically that I toured, and definitely a medical innovation, and kind of partnering up with Cook is they have the heart catheterizations, but what this company has done, they developed a little plug when you pull out the catheter, instead of having to stand there and hold for, and I used to work as a CV nurse, you know, and holding pressure, to put a little plug as soon as you pull out the catheter. And that business is still going, but it was because of the money that they received through the 21st Century program. So we've got to maintain our commitment to that. There's something called the New Market Tax Credits that might help some of our smaller businesses and our startup businesses. But again, that'll cost us a little bit as a state, but is it worth the investment? And I believe it is. And then in talking with folks that are with the larger organizations and that are global, how do we provide a tax environment in the state of Indiana that is going to allow them to practice globally and compete globally, even within their own company, to say, you know, we want them to base here, and that's, again, having that strong tax environment. So those are some strategic ways that we need to be thinking as a state. What you can do to help also is help educate us as legislators. As I said, come talk to us and tell us you got to get out of the way, Peggy. You know, this is being an obstruction to us. It's a barrier for us to be successful in creating medical innovations. But that includes, and we've talked about this before, haven't we, Kristen, about maybe having some type of bio caucus at the State House of educating us, teaching us. I'm very fortunate. I live in Bloomington. I have Cook. I have Baxter. I have Bioconvergence, and I could just go on and on. But there are a lot of people in the state that aren't aware of what happens at Cook or Baxter or what's going up in the northern part of the state with all the orthopedic industry. I look forward. I want to go for a tour there. I want to see it and feel it so I can better relate that to and translate that into policy. But you've got to help us do that. You've got to get our attention. If you live in an area where you've got something going on with innovation, you need to call that legislator. And you need to invite them to breakfast, invite them to lunch, and come and see your shop, or explain what you're doing, whether it's in health information, whatever it might be. We have short attention spans. And, and it helps if you grab us and say, let me show you this and teach you this, and you're going to be much more effective than when you're asking for us to change policy or to make policy that's going to help you. I just want to mention a success story, and then I'll be finished. We heard from several organizations that there was a real problem with vendor credentialing within hospitals, and that it was costing a lot of money. In fact, it costs about $400 million a year to life science industries to be able to, and that's nationally, to go into hospitals and get their vendor credentialing. We had some legislation that was introduced, but we didn't push forward because we had a commitment from the industry and from the hospital association that they would sit down and that they would work together. And we just had a report in Senator Miller as the chairman of the Health Finance Commission, and we had a report just yesterday of the success of the industry, the hospital association, all the major players sitting down together and coming up with a policy of learning from each other. And in talking with some of the folks, they are getting phone calls now from around the country who are saying, how did you do it? And I want to report that it's because we have legislators in the Indiana General Assembly who are willing to work together, whether we're Democrat or Republican, House or Senate, because we want to do the right thing. And then we had folks out in the community who said we are willing to sit down and communicate and talk. And that's where it really comes from, is communication. So I challenge you to communicate with us. Thank you.
Representative Brown?
Thank you. That's a lot. I don't know, Peggy, with her background both in tax and health, really did cover a lot of areas and covered a lot of different topics important to all of us. I feel kind of like the thorn with all the roses here, so I'm much out of place. I think I'm going to be a little bit briefer and think there's a few areas that we can think about and just take a little bit different tack. I too want to talk first about some success stories, and being from the other part of the state where the other major Big Ten university is Tippecanoe County, I'll talk about Purdue and what Purdue has done around the state, and to look at the research park influence that they have across the state, very innovative, to bring in research dollars, but also to engage different parts of the state because they have gone out and physically put physical plants to try and bring research dollars and people together. I think one of the other things, though, it's more on the manufacturing base, what is the TAP program, Technical Assistant Program. Initially started for the manufacturing base, but I think as we bring products to market, Purdue and their bioengineering department would, through TAP, be of much assistance to companies to try and streamline their business, to look how they could be innovative. It's a wonderful program to outreach the basic science into the application of business. And then lastly, I can't, I guess, crow enough about Purdue and Discovery Park and just being innovative with the idea of having Discovery Park up there and what that means. So I feel real blessed to be part of the Purdue community. Along with that, we have done some things at the legislature, but we continue to need to look at intellectual property rights. This is a very important point for the innovation. If we look at what is going to be the next breakthrough, is that going to be done at the university level? And how much of a share does the university get of that intellectual property right? How much of a share does the individual professor get or the team that developed it? And then, since the state has some input in that, are there any combinations there of state dollars? Do we get enough just through the tax revenue that a new product in Indiana would bring? I think it's very important. For the future, those intellectual property rights are the most important thing to grow and to know that they're secure. Part of that uncertainty that Peggy talked about is why develop a product if you think it's going to be pirated or stolen away or a professor's going to go to another university. It very much becomes a long-term care or long-term issue. Along with that, I think any medical device that we look at for the future, is there a reason to put that new device out on the market? I think one of the concerns that I just personally had with the Accountable Care Act was the tax that was going to be placed on medical devices, and was that going to be a big impact to our medical device industry in this state? We haven't seen it yet, is that in the future? But we'll need to continue to have those discussions because we at the state level maybe could have some state tax policy to mitigate some of the federal tax policy in this specific area to protect them. And then the last area I think that maybe we haven't talked about, and that's energy. Energy policy in the United States is going to impact what we do in Indiana because we are coal-based. We are coal-based, and to have that certainty for the future, we need to have coal, and we need to have a coal supply that's predictable and not too expensive. So if your business is going to run in Indiana and you're looking at what your costs are to do business, it's human capital and education, but then some of the next areas is healthcare and that benefit, but then it's utilities and what your energy is going to cost. And especially if you're into manufacturing, bringing a product to market, you want predictable energy prices. Thank you.
All right, great. Well, first of all, let me say how good it is to be back in your company, Kristen. She and I worked together the Indiana Department of Commerce, and I know for a fact she's a very bright and talented person, so I'm sure she will be a very wonderful facilitator for today. How many languages do you have under your belt, Kristen? About 3 or 4?
Enough.
Yeah. She was very capable and adept at the international trade part of her job. First of all, let me say it's a wonderful opportunity for me to be here. I appreciate very much the invitation. I believe all of my colleagues are in some way or another affiliated with the healthcare arena. Tim did not mention it, nor did Kristen, but I believe you're a physician, aren't you? So he's a physician, Peggy's a nurse, and Pat is also a nurse. But I am an active consumer of the healthcare industry, so I will come to you from that perspective. And as a consumer, I find that the healthcare industry is it's very fragmented. It's a collection of fragmented, non-communicating silos. And as the patient, I am required to do an awful lot of legwork in the process. I'm required to be on top of all of my information because I can't promise that my physician, since they don't really have access to my complete comprehensive picture, is aware of what I need. So I better be well aware of what my medical needs are, because if I rely on someone else to do that, I could be in trouble. And I can cite one example where I had a particular illness that I was having addressed, and I had some physicians in there, and they were all looking at it from one perspective and were ready to do this big major thing. And I said, just turn that little thing over, and you'll see that it's not a problem at all. And lo and behold, it wasn't a problem. But luckily, I knew to tell them to do that. So as a legislator, I think we first really have to understand the healthcare industry. And then we need to examine what's working and what isn't working. And that's kind of what I hope. I hope the Affordable Care Act will remain intact, because not only does it provide access, but it also introduces some new thinking into the process of healthcare delivery system. As the first thing that I think needs to be addressed, or maybe not the first thing, because I really don't know just quite how I would really organize it, but I know what needs to be a part of this whole review of the healthcare delivery system is the introduction of what Christian is involved in, and that's technology. We have to use the technology that is out there and use it in a way that will reduce the cost and increase the quality of care that we provide in this country. I don't know if it's a virtual environment. I know that there are opportunities for e-prescriptions, but the most important thing that I see is the electronic medical records. There's got to be a way to somehow and I've done some research on data collections here in Indiana, and it's really, there are just so many different systems out there, and if a person changes a physician, that physician, particularly I've been looking at this as it relates to prenatal care in our state, and what happens is we have a system at the state that can't be accessed until after pregnancy, but all of the information that we need to prevent infant mortality comes before the child is born, but it happens in different sectors, and most women who have difficulty accessing care go to numerous physicians before the actual birth of the baby, and none of them shares that information. And so we have a very fragmented system, and we have a system that needs to use the technology to bring those records together and to bring the different other technologies that are out there related to healthcare so that we can reduce the cost of healthcare. The process in hospitals, we have far too many accidents that occur that cost us money. We have far too many misdiagnoses. We have far too many errors that occur that cost us money. And so we need to bring a group of people together, whether it's Dr. Evans or others, and sit down and let's look at the processes in hospitals, because there needs to be a way that we can eliminate the waste, we can eliminate the error, and we can reduce the possibility of losing a life because errors were made in the hospital setting. And then we must, and I won't go through all of my whole list, but we really also have to empower the consumer. We have to empower the individual to not only want to live a healthy life, but we have to figure out incentives that will induce them to do that. so that they can recognize the value that is inherent in our healthcare system. So, as a state legislator, we need to look at what are the ways that we can incentivize people to want to purchase good quality fruits and vegetables. Right now, if you really want to eat healthy, it costs you a whole lot more money. I mean, it's very expensive. So are there incentives that we can give into the farming community? Are there incentives that we can give in the retail environment that will help reduce the cost of some of the better foods so that we can encourage and induce people to make those kinds of purchases? Maybe there's something in our those populations that receive TANF and other kinds of services, that there are things that we build into that will make it possible for them to get more positive kinds of foods in their refrigerators through that process. So behaviors have to change. So there are an awful lot of things that we as legislators need to understand, and in order for us to do that, I think we need to bring the people together at the table who have the information and who have access to the understanding of the issues. And then we have to not only bring those folks to the table, but we have to continue to go, as Peggy said, to National Council of State Legislators and other places that are resources for gathering information. And then as legislators, we have to go through it and make the best decisions that we can that will promote quality health care, that will improve the processes, that will include more IT into the process, and will give us all better access to quality health care.
Thank you, Jean. Senator.
Oh, well, thank you. I'm pleased to be here, too. I don't know that there's much of an advantage to being last on this panel. I think you probably also learned that we're all capable of being able to sort of filibuster on this issue and go on and on, because we all, well, that's just what we do.
Yeah.
So I'm going to try to, I'm not going to use the word be brief, but I am going to try to mention a few things that haven't already been mentioned, and try not to duplicate some of the points that have been made. But I just, to begin with, in 2004, the American Medical Association did some research, and what they found is that private industry, not government, is the primary financer of medical research. So first of all, government is not the primary provider. It is, in fact, private business. And so one of the best things that we can do as a state and as a federal government is to make that business more able to function under regulations, or hopefully with less regulations. But Representative Welch mentioned the 21st Century Fund here in Indiana. We have given money for research and development, and we've looked at things with those funds like a software map for chemical makeup of new drugs. We've looked at how you can fight cancer to how you fight cavities. We've also created the program at Purdue that Representative Tim Brown mentioned. But for example, to bring a new drug to market, it costs between $55 million to $1.2 billion, all of that time. And so people want to know why drugs are so expensive. It's because there is so much invested into bringing a new drug to market. We have provided tax refunds, tax incentives for business to engage in research and development. We are the second largest state as far as pharmaceutical jobs in the country. Number 2, Indiana. We are the 5th largest pharmaceutical industry in the country. And I would like to see Indiana become the medical research center of the country. You know, we have had other areas of the country who've become famous for certain kinds of development, and I believe there are many people working towards that, including Dan Evans, who was here earlier, in helping Indiana to bring more and more technology, more and more research, more and more chemical and biochemical research and development here to Indiana. Clearly, Regan Street is one of the areas where we're doing a lot of things with technology and research. Technology is absolutely critical. I want to say just a word about ethics. Nothing's been said here about medical ethics. But in the state, we have passed some laws to address medical ethics. And some of those, for example, are in the harvesting of organs in deceased individuals. We have a law that says if you do not have either the individual's previous consent or the family's consent, you cannot harvest organs unless you have that consent. We also have language that says you can't buy organs for transplants. We don't want this to become an economic area where people with the most money are the ones who get, if you will, organ transplants. So we've tried to deal with that. I want to talk a little bit about patient safety and quality health care, which Senator Breaux mentioned. I serve on the IU Health Patient Safety and Quality Committee, and I think people need to understand how much time and effort institutions are spending on quality and the minutia that they go through to make sure that every I is dotted, every T is crossed, how they look so hard to make sure that everything is perfect, because in healthcare there is no room for mistake. But I don't want anyone, I do not want anyone to think that any healthcare provider takes that lightly. And you see new changes in the system to make sure that those don't happen. That we are human beings, and the issue is we have to have systems that work, because individual human beings will make mistakes. But if you have a system that is in place to prevent those errors from occurring, you will see much improvement in healthcare. So I just want you to know, I know that hospitals across the state and across the country and physicians and nurses are all wanting to avoid any kind of error or jeopardy to a patient. So there's a great deal of effort and, frankly, a lot of money and a lot of staff time going to those things. And then I also just want to remind you that people in the healthcare industry are the experts. I'm a registered nurse. Peggy's a registered nurse. Dr. Brown, of course, is a physician. But the people who are working day in and day out in the area of healthcare, as the providers here on the panel, can bring expertise, but there are others. All of you are experts in your field, and you need to talk with us because we don't know everything. We get niches at the General Assembly, but no one in the General Assembly is an expert in all areas. And so, as was outlined earlier, we really do need to have you communicate with us, sit down with us, and talk with us about what things we can do, how we can help with making it easier for healthcare providers and industry and business to, if you will, move forward in the whole area of healthcare, and what we can do to make healthcare more cost effective, and how we can make research and development more cost effective, and how we can help with granting and all of those kinds of things. So I'm glad to be here. This is a very, very important issue. It's certainly something that that I value very much, but I recognize that there are many other people that have expertise that need to share with us in the General Assembly so that we can come up with the best public policy to allow all of you, and particularly the private sector, to move forward in the area of healthcare.
Great, thank you very much. Well, you all certainly were very thorough, because I think you've gone through the complete list of questions I had to kind of follow up with. So we may move on to the audience question piece of that pretty quickly here, but just a couple of things. One is I would volunteer that we are working very closely with the Indiana Medical Device Manufacturers Council on developing a health science interest group for the legislature, and we'll be talking a little bit more about that coming up in the next month or two, so keep tuned, and we'll get there. I also am quite clearly hearing the plea for more input.
That's right.
I think that piece is very clear, and one of the questions I have, and Jean, maybe you touched on this, maybe one of the best in as a legislator who's not actively involved in the industry, so to speak. What would you say might be the general understanding of the health and life science industry amongst most legislators? Is it high? Is it low? Do we have a great number of people with expertise?
Well,
Who might we be dealing with as we're talking?
I represent Indianapolis, and I think in Indianapolis, because there are several corridors that are being established now, and I think you all have been very effective in promoting the life science industry as one of the industries that we should focus on in Indianapolis. I know we've looked at doing motorsports, we've looked at doing college athletics, and I've also heard life sciences being one of those, as well as transportation and that sort of thing. So I think life sciences in Indianapolis is well known as an area that we would like to see grow and develop here. I think you also have pockets across the state where you have manufacturers, large manufacturers, and Peggy mentioned Bloomington, and I know sort of up in the northeast part of the state, I think there are. So I think in certain pockets of the state, yes, those folks who have an industry that typically tends to be a huge industry in that community and a key provider of employment. So I think those communities also are very knowledgeable about it. But absent that, I would say we probably have a lot of work to do in the state to increase the understanding of what just is life sciences and how life sciences can be used to further a lot of areas of need in our state.
Senator Miller, you were very involved in the development of the Healthy Indiana Plan
Yes.
and how successful that has been. Do you see a continuing role for an emphasis on personal responsibility in healthcare and development, and how do you see that kind of playing into things?
I do, but I'm not sure the federal government does. And I want to speak to that for just a minute, because I wholeheartedly support the Healthy Indiana Plan, because I think the best way for us to help people facilitate good health is to give them some responsibility for their own health. And so the Healthy Indiana Plan encourages wellness. It actually requires that you have an annual physical, and for women of a certain age and older, the mammograms and PSAs for men are required as a part of that wellness program. So I think that's very, very important for individuals to have a personal responsibility for their health. Unfortunately, the federal government has yet to tell us whether or not we're going to be able to use the Healthy Indiana Plan. And when the new federal health plan takes effect in 2014, unless we get permission from the federal government, the Healthy Indiana Plan will no longer exist. And I'm very concerned about that, because I think it's an excellent plan. And quite frankly, we in Indiana would like to use our Healthy Indiana Plan as an expansion of Medicaid, so as all the people who come on as a result of the new federal health care plan would come into the Healthy Indiana Plan. And the prediction is as many as 500 to 700,000 additional people will come in on Medicaid. And I don't know if you're aware, but the Healthy Indiana Plan is actually a Medicaid waiver. So if we do not get that waiver renewed through the federal government, we will have to go to some other plan. And I really am committed to the Healthy Indiana Plan.
Great, thank you very much. Representative Brown, as a practicing physician, what role do you perhaps see for public-private partnerships and innovation in healthcare delivery?
I would
Sorry,
like
I'm
to.
going off the canned questions here.
Yeah,
You took all my
you know,
good
I
stuff.
think the sky would be the limit to public-private partnerships. You know, again, I kind of look at maybe the model that Purdue as a public university educational institution and trying to develop. And some of the things that have been, some of the things that Peggy talked about, I know there's technology up there that can take a drop of blood and do the assays of, you know, more than just a comprehensive medical profile, which is about 20 tests. I mean, can try to look for markers for cancers and record that. You know, that we could do that with a lot of people if they so desire. But that technology going to the you know, the front business product line still is not there. But you know, that was, you know, years ago that technology could be done very expensively. So I think there would be a lot of interest in that. I don't think you're going to get us as state government funding anything that's going to be marketable anytime soon because of the budgetary nature of the state and what we put our emphasis on. You know, we put our emphasis on education. You know, the lion's share of our budget's education. Number two is Medicaid, and we're just barely clawing at Medicaid to have enough providers and provide access because it doesn't pay well and people don't want to participate.
And Peggy, perhaps maybe direct this to you. You had such a great listing of things that we all should be tackling and paying attention to, And actually, a lot of it fits right in with some of the strategic planning that we're doing. One area that people haven't touched on so far maybe is rural healthcare delivery and telemedicine and some of those aspects. And I know particularly around the Bloomington area with some of the work that Smithfield Digital has done down there and expanding broadband access and getting people tied more into some of those networks. Is that something that you think there is a role there for perhaps more investigation or more education for people?
Absolutely. I was just visiting 2 weeks ago with the superintendent of the schools in Mooresville, which is a part of the new district for District 60. And I was so surprised to learn this is Mooresville, just right outside of Indianapolis, and they don't have connectivity. They don't have access to the internet easily. And so a lot of the families, and it's not economics, it's just availability. And that's right outside of Indianapolis. What about all the other areas? And so I'm hooking them up with Smithfield and AT&T and others to be able to explore what they can do to be able to have access just for educational needs, but obviously for healthcare. You know, there was, several years ago, we worked on a grant through the FCC to be able to provide that telehealth and connectivity for our rural areas. And it kind of goes back to what we were talking about earlier in the forums of so many things to hoops to jump through to get people to be coordinated. And it was quite difficult for Indiana to move forward in getting that grant from FCC to be able to provide connectivity for our rural areas. And that's what it specifically was for. And we do now have a rural caucus in the legislature, and that's one of the things that there has been a focus on is how do we provide good health care, and it's not just about technology. It's those critical care, critical access hospitals, then how is that information shared. And so it's just so many layered. That's what's exciting about it. But it takes a lot of work, and somebody had used earlier that a lot of blood, sweat, and effort to be able to make this happen, and that's what we've got to do.
Could I speak to that as well?
Absolutely.
A few years ago, I was concerned about the issue of the working poor. You know, people who have resources, financial resources, can have health insurance, and then those who qualify for Medicaid get health care. But it's the people in the middle, the working poor, who were not accessing health care in the best way. So I proposed a study. We did a 3-year study on the working poor, which not only includes rural, but urban and other areas as well. And what we found out was the best way to provide health care to those individuals was through community health centers or federally qualified health centers. And here in Indianapolis, I'm also from Indianapolis, as is Senator Breaux. On the east side, we now have the Jane Pauley Center, which is a partnership, but it's providing health care to individuals who have no other access to health care. It's a great plan. It's an example of what we can do. And so I just wanted to lift up that community centers and federally qualified centers are an excellent way for us to help individuals who don't get health care to receive health care.
I just want to go back to your point on telemedicine because I think it's going to be vastly important. If we look at the example of Massachusetts and what they did under health exchanges, and if looking at the future, there's going to be a lot of people who want health care, and there's not going to be access. There's not going to be the providers out there. You look at the manpower numbers out there, and we need all sorts of man and woman power out there. And so telemedicine, I think, is going to be greatly needed, because one of those issues I see all the time in the emergency room is I didn't even want to drive to another county where my doctor was. I'd rather come to the ER. And so would there be a way to hook people up so that they could have that, you know, less costly ER care for some of the simple things as a blood pressure check follow-up or just for the upper respiratory symptom check. So it's going to be vastly important for that.
And that's kind of following up on what Dan Evans said earlier about just compliance. Even if just using it for compliance to make sure that they don't have to come back to the hospital, which I'm pretty sensitive to as an employee of IU Health, is that if that person comes back within 30 days, we don't get reimbursed for it, which could affect my job security eventually, besides quality health care. And so I think telemedicine will be able to help just to be able to, if nothing else, just with compliance.
Well, and I'm going to jump in too, since you guys have all answered that one single
It's open
question.
season. Go ahead.
I also just want to think that we need to look at how we use the virtual environment as well, and also perhaps the way nurses are trained, that we can provide some kind of a training program that puts more responsibility in the hands of nurses so that they are able to do some of the things that doctors do. And I know we have those types of nurses now, but we need to look at a licensing program and increasing the number of those, particularly as we see a shortage in the primary health physician. So they're a way to utilize the talent that we already have out there and give them training so that they can do a little bit more in the rural communities.
Well, thank you, everyone, for your remarks so far. With that, I would like to open it up to the audience for any questions you might have and a chance to help educate our legislators a little bit on industry concerns.
I may have missed it, but could you explain more what the Healthy Indiana Plan is?
Sure, okay.
Go for it, Pat.
Yeah, sure. Okay, well, first of all, the Healthy Indiana Plan is a plan that was developed to help people in the poverty levels to purchase health insurance. And they pay on a sliding scale. They buy health insurance like you have. There are 3 companies. One is Anthem, so they can buy whichever plan they want. On the sliding scale, the individuals at the lowest income level pay $160 a year for health insurance, much like you and I pay. So what we have done is we've gotten a waiver from the federal government that we can invest money in their insurance plan. So the part that they don't pay in insurance premiums, the state of Indiana pays. But it requires wellness. It requires that they take some personal accountability for their own health, and we expect certain activities from them as a result of that. So it's essentially a state underwritten health insurance plan for individuals living in poverty who do not qualify for Medicaid and who do not have private health insurance.
In some of the group that it really got to was the parents of children who were on CHIP. The kids were in CHIP, Children's Health Insurance Plan, a part of Medicaid. You know, we tend to use Medicaid as being one entity, but if you really think, there are now about 5 or 6 different parts of Medicaid, and CHIP is just one part of Medicaid, HIP is one part of Medicaid. The other aspects of the program is it has a power account, and that's what Senator Miller was talking about for the preventive services, that you have a $500 power account that goes for those preventive services, no questions asked, you go out there. And then there's $1,100 in basically a modified or semi-modified HSA account. And then after that, it's like traditional insurance, it's reimbursed at Medicare rates to providers. So the client doesn't see, I mean, it's an insurance product to the client. And one of the important points, as what Senator Miller said, is that the lowest rate is now $160 a month, and you think, you know, are there people?
A year,
a
$160 a year.
I'm sorry, that's correct. About 10 to 15, yeah, $10 to $12 a month. That, you know, are there people that can even afford that? Should it be zero? Are there people out there that are truly the working poor that are zero? What we found in the first few years, that if you even asked $10 a month, that ER utilization went down 16 to 18% with that little amount of payment. And when you surveyed the clients in this program, they, at the 90% level, said they could afford $10 a month.
And they probably felt as though they had more ownership in the process.
And it also provides, there's a segment of the funds set aside for adults without dependents, which is unusual also. That's a very underserved crowd. So, could I ask a question?
Sure.
I have a real interest in what's evidence-based, and I was recently speaking to a group that's an accrediting organization for health plans and other things, and I was on a panel and had a woman come up and talk to me afterwards, and we were talking about how we overutilize, though, medical innovation. And she specifically used the Da Vinci robotic tool for especially prostate surgery, and that it's not showing really much difference between a regular, surgery and a robotic surgery. And so that's the kind of stuff that we need to understand as legislators too. What is the evidence with all this new innovation? Is it costing us more? And are we really getting the best service from that medical innovation? I mean, it's fun and it's jazzy, but is it really doing anything better than what the old system used to be? And those are the kind of things that I have an interest in also, that because of your interest in medical innovation, that's what we're specifically talking about today. Help us to understand that at some point. I don't know if there's any feedback on that, but that's something I find of real interest. Nobody jumping
Well,
up. But
Chance, people.
While you're waiting, I'd like to say something about innovation and research and sort of piggyback what Peggy was talking about. If you all remember when we first computers came out, they were bigger than this room, cost millions of dollars. I don't know how much a computer cost. But now everybody's walking around with one in their pocket. My grandkids can use this better than I can. And so I think we need to realize that early interventions, early inventions, if you will, early technologies may be expensive, but in the long run, they may be very cost effective down the line. You know, I know that was a time when cataract patients had to lay on their side for 10 days with sandbags by their heads so they didn't move, and now they go in and have a cataract removed, and 2 hours later they're home mowing the grass or something. I mean, maybe not quite mowing the grass, but it's but if we don't go through those stages and that refining of research and technology, then we won't take advantage of the kinds of opportunities that we might have in healthcare. And you look at CyberKnife and other kinds of surgery where, you know, early radiation was a shotgun, and now they've got the ability to be a rifle and put it right on the spot. So we really do want to develop those kind of technologies.
But do we have a fiscal responsibility? I mean, there's this tsunami coming.
Correct.
How do you balance that? I mean, I hear them talk about personalized medicine, and it's great, the things you can do, but how are you really going to balance that with what we're spending now?
Well, that's why we're here to listen to you. But I just didn't want us to throw the baby out with the bathwater, because we are in this balancing act right now of how we're going to pay for health care. And quite frankly, a few years ago when we looked at this, the thing we can best do to reduce the cost of health care is for us to live a better, healthy lifestyle. And I sit here overweight. But if we could stop smoking and obesity and a whole handful of things that people do to themselves, healthcare costs would drop like a rock. But so it's not necessarily research and development that's causing the cost. In many cases, it's our lifestyle.
Well, and you know what, I was just doing some research, and it was saying that about 75% of our costs are focused on 5 major areas of disease: diabetes, coronary artery disease, depression, and a few others, heart failure, and so forth. And so I think we need to get a handle on, for example, diabetes. A lot of that is attributable to health style and how one lives. And so we need to really break down those 5 areas of the biggest cost to us and figure out where we can, at an earlier entrance, try to be more preventative and try to really emphasize the kinds of things that will prevent these diseases from happening. And I think that will save us a considerable amount of money as well as make us healthier.
I would maybe follow that up with, how do you see, and this is for, I'll open it up to anybody on the panel in that case, separating healthcare delivery and the costs associated with that with the need to support growth? Can you completely separate those two, or does there have to be a tie-in between those two?
Growth of the industry?
The industry.
Okay. Oh, yeah, that's a
Say
good
the question one more time.
That's a good question.
Can you separate the need to pay for public health, for healthcare delivery, with the need to support innovation in the industry? Are the two necessarily completely tied
and
together?
if you look kind of a historical perspective, I mean, that's part of the issue of how Medicare has kind of gotten to the point where it is, because Medicare started out as a cost-plus reimbursement system. And if you look at the technology boom that has started over the last 100 years, Some of it was the money that was infused in a cost-plus reimbursement system, because you could say your cost of innovation or research or technology was cost plus you got a profit. I mean, if you look at how it all started, it was when the federal government got involved in that cost-plus system. Now that we've gone the other way and say, no, you've got too much money for too long a time period, that is a concern, because you can't divorce, the clinical setting, I think, from what's happening if you want to put it into practice. One of the things you talk about, evidence-based medicine, we really haven't proven that bypass surgery lengthens lives. I mean, it helps with chest pain, but does it actually let you live longer? But yet we've done bypass surgery for a long, long time. Who's going to do that study that denies bypass surgery? So I think those are the issues we get into.
Well, and I'm going to say, I think you need to find where we can get the most savings. Where are there some inherent savings in the system? And let's pull those out, and with that additional money, build up the industry so that we can continue to find more creative and innovative ways to find those savings and pull them out, and it's make it a cyclical sort of process.
I think we have a couple of questions there in the back. Gentleman in the back.
So from a holistic perspective, and I've spent a lot of time with the American Diabetes Association, was a former national chair, and I think I've testified for some of the committees at the state level for a while. But from a holistic standpoint, looking at the health, the prevention, the obesity issues and things like that from the state perspective, I'd be curious. I really do think that the solution to the healthcare issue, beyond the technology and beyond the economics of just the patient delivery perspective, it's really getting the community around it, and it's taking a very holistic approach. So my question to you is, when you're thinking of things like zoning laws, when you're thinking of things like, are we going to build parks? Are we going to build mass transit? Are we going to build things that are going to allow people to live a healthier life? Is that going in is the health aspect or health impact of that going into those discussions? And I would just encourage you to keep that part of the dialogue as well.
We had Eli Lilly several years ago lent to the Department of Health an endocrinologist who was helping advise, especially the health leaders, on how do you affect obesity. And that's when we were talking about getting the vending machines out of the schools and PE classes, which in our conversations, that was all low-hanging fruit. It's looking, how do you change society? How do you change the culture? And so you're talking about that we think about having complete streets, that it's not, it's just automatic. Obviously, we're going to have a complete street policy. And I don't know that we've still gotten to that, to really come together with a think tank that pulls together all the different parts, the moving parts that are needed to shift the way we think as a society.
It's not easy.
But that's the whole part of changing behavior. And I don't know if you start at the top or the bottom for that, but it definitely has to happen in order for us to really maximize this healthcare issue.
Do we have another question up here?
The organization I work for supports the healthcare safety net in Indianapolis, and I went on a site visit recently, and the results they are getting are tremendous. They are serving the population you're talking about, the working poor, the homeless, yet they operate on a shoestring budget, and they operate with a clientele that is afraid to go to the emergency room, that is afraid to give any information that might get into government hands. But one of the things she pointed out was they are doing a study on their clients, a diabetes study, and now a high blood pressure study. And they are committed to following up with their clients, to getting them back in the hospital, or not in the hospital, to getting them back to their clinic on a regular basis. And what they found in the diabetes study was 85% of their clients were meeting the goals that were set out on lowering whatever it is you need to lower for diabetics. And in their high blood pressure study, they haven't completed it yet, but they're getting the same results. Over 90% of their clients are lowering their blood pressure. And it's all of a matter of staying at them, of getting them back in for regular checkups. So it's not something that costs a lot of money, but it's something that gets proven results. So I would encourage you to talk to those providers that are the healthcare safety net, that are sort of outside the system, that don't get reimbursed from these insurance plans, that aren't getting reimbursed from really anyone. But those are some important people to talk to.
I think we heard that earlier today from some of the presenters, that it's engaging them, and that one of our speakers, I think he may be gone now, Mr. Goldberg, made mention, that being poor doesn't make you, ignorant, so I appreciate that there are things that we need to do to be able to engage people, that they want to be healthy, if we can help them get the information.
That kind of reminds me of a story that I just came upon as I was getting prepared for this, and it had to do with physicians in hospitals, and once they were discharging senior citizen patients, that the senior citizen patient would leave with an abundance of medications, pharmacy medications, but the senior citizen was so interested in getting out and getting home and getting out of that hospital setting that they really didn't pay any attention to the instructions related to how you use those medications. And so they were finding that a significant number, and I don't remember what the percentage was, of those patients, senior citizen patients being released, were coming back because they had overdosed or misused their medication in a way that put them back into the hospital. So what they did was they went out, and a couple of days after that patient was released from the hospital, they would have someone call from the hospital just to go over their meds with them to make sure that they knew what they had and that they knew how to take them, and that I think it was about an 87% recidivism rate was reduced to 4%, just from that interactive ability and the sharing of the information, and finding pharmacists that knew how to really interact with patients, and having doctors release the information, and just coming out of the silos and reaching out and touching. And I think that's got to be a part of this whole process.
I would agree we need to look at different ways to tackle the problem. I guess I have a little bit of concern, and maybe I'll be the naysayer, in that when we talked about, is there a coherent policy from federal, state, and private industry, and there is not. Because the federal government now is more worried about the paperwork than the patient care. I have to worry about whether I document the decision time on the chart of when I'm releasing a patient as opposed to how I'm instructing that patient. And I'm going to get dinged on that on payment if I don't have that blank filled out. And that's very concerning. The other issue is because of the federal law, especially on physician providers in Medicare, if there isn't anything done, there's potential 30% reduction of fees, and you're going to see access problems to the Medicare population. There's not a coherent policy to spend more time at the patient's bedside, at the patient in the exam room, from both a federal, state, or private level. It just isn't happening. So, if you want that, we are, as a society, going to have to say that, because we don't have that.
And that's part of the process. It's definitely the process that needs to be addressed.
Absolutely. Any other questions? I know we're standing between you and getting close to the end of the program, so. Yeah. Oh, yes. One more.
I can't resist one question. So on the issue of telemedicine, well, first of all, thanks for spending all this time with us today. It's really appreciated. It's a good discussion. Do you see are there any issues around medical malpractice or other kinds of things that would impede the increased use of telemedicine and some of the remote care delivery ideas that might come around?
I think in Indiana, we're very fortunate to have a medical malpractice law that has stood the test of time since 1975, that has a medical review panel in place that is kind of the first step to look at this. So you have a peer review, if you don't understand what happens, a patient files a complaint with the Department of Insurance, and then a medical review panel is formed of like practicing physicians to give an opinion. And then if the plaintiff, if the the person making the complaint or family making the complaint still can go forward with a lawsuit, but that medical review panel can be given forth in evidence at trial. So we have a system in place. I think there's always continued worry from a practitioner standpoint about the medical liability and what will happen in the future. I think what's also happening and maybe needs to be addressed is that if there's an untoward event, for whatever reason, there tends to be an initial complaint filing in a wide dispersed pattern, thinking that it will be narrowed down at the end. And that just takes a lot of time and money and effort in that. So I think you'll see some practitioners bring that up in telemedicine. Because one of the things as a practitioner isn't necessarily the number of times I've had a complaint or been sued, but it's the fear of being sued. And I think you see a lot of activity and utilization based on that. You know, how many tests are ordered because I'm worried about being sued, as opposed to the actual fact. That's back to the low-income population. Most practitioners, if you poll them, would say, well, they're worried about the low-income, the Medicaid population suing more. And if you actually survey it, they don't. They sue less. But you can't get that through the mindset of practitioners. So it's the fear of being sued is much higher out there.
My understanding is that there are states that are employing the use of telemedicine more than we have here in the state of Indiana, because they also provide reimbursement for telemed.
Reimbursement is the biggest issue.
And I have not heard or not been told of those states having an increased problem with malpractice and with suits any more than usual. But it's definitely something that we need to look into to employing in the state.
Peggy asked a question, and maybe I can ask it as a final follow-up. There's part of the new federal healthcare law about IPAB, the Independent Practicing Advisory Board. Is that going to be a problem with innovation in medical devices or looking forward, and how do we feel about IPAB?
On the flip side of medical malpractice isn't also the existence of the fee-for-service system at some fault in terms of the increasing prices of healthcare, and in particular the disproportionate workforce that's part of the MD population that's in specialties, and they in turn drive the cost of healthcare, and they aggregate in, of course, urban areas where there's a better lifestyle, et cetera. I mean, fee-for-service seems to be an issue that needs to be addressed, yet no one wants to address it. It doesn't seem to matter whether it's on the left or on the right, because we've been in this system since 1965 in Medicare, government setting the prices, and you know, we're not going to change. You know, the medical industrial complex is settled in the foundations of this society, and nothing will shake it.
And I guess that's also back to a little bit of utilization. You raise a very valid point about fee-for-service and how, you know, in the Medicare population, especially when you have seen the potential for this cut down, you've seen volume go up quite a bit. And that's part of the whole issue about provider reimbursement at the Medicare level, because it's tied to volume. But part of that all started, and let me tell you this with an anecdotal story about when I was a resident. A local surgeon was trying to figure out how much he was to charge for a procedure of suturing something up in the emergency room. And he said what he did is he had a charge and charged it out to the insurance company, and if they paid 100%, the next time he did the same exact thing, he doubled it. And if they paid 100% of that, he doubled it again, until they didn't pay 100%, and that's what he set his price at. Now, the reason that becomes an issue is back to another thing I see in the emergency room. I'm seeing 90-year-old people on dialysis at a much markedly increased level. And part of it is because they're divorced from the financial reality of what that means, because somebody else is paying for it. As long as we have that disconnect and we have fee-for-service in there. The provider doesn't care what the fee is, the patient doesn't care what the fee is, and it's all a haggling over here. I think if you get back to that communication, you will have more responsibility in fee-for-service, because there will always be fee-for-service in a lot of different areas of the United States. I also use the story 1985, when I was first starting practice, our fee for an office visit was $20, and 98% paid at the time of service with cash, $20. And I had a half of an employee, basically one employee for 2 doctors doing the collection. When I got out of the office practice in 1999, we had 3 full-time equivalents, and our office charge was $80, and we were only collecting about 30 to 40% at the time of service.
Don't know what that was. Well, thank you. Any last questions? We have time for one more.
I just wanted to respond to your question on IPAB. So in the comments Bart Peterson made earlier, when he and David Johnson were talking about the importance of the life science sector here and the great things that we've been able to accomplish, he noted that there's a threat that could come from things like rebates enforced on Part D and some of the other proposals that are currently under debate. The IPAB, I think, so I'm full disclosure, I'm also with Lilly, and so with regard to IPAB, I think one of the themes that we picked up earlier in these discussions was that uncertainty causes a great amount of distress within innovator communities, because we already deal with a very high-risk business, and so anytime we get that level of uncertainty increased, it makes it harder for us to do what we need to do. And I think the other concern that we would have with the IPAB is that it just concentrates the decision-making in a very small number of people, and so the threat that arbitrary decisions that are focused on one end or another could be very difficult to undo, and the consequences could be pretty severe and not necessarily intended. So,
Thank you.
Well, thank you, everyone. Please join me in thanking our panel today. We have, I think we will be in good legislative hands if this is what we have to work with. So thank you all very much for your participation.
In closing, I would be remiss if I didn't thank every moderator, every speaker, and my audience, because it was just a memorable, exciting, and a really rich conversation that started in the morning and is ending with this amazing panel. Thank you so very much for making our day, a gangbuster day and a great ending. I also want to thank our sponsor, Eli Lilly, and I want to also thank our sponsor of our new, soon-to-be-released white paper, WellPoint. And this is not, yes, and you're all going to be invited to Washington, which is where we're going to have the event. Oh, yes. Visit us on our web. You'll see that the events as they unfold, but it's going to be in January, and it's going to be just a terrific next step in the Voices from Main Street. This does not happen, no conference happens without a small army. So I have to thank, and I had to write them down because there were so many people I have to thank. Well, first of all, Mark Godfrey, Roger Harvey, Mike O'Connor, David Baer, Lori Leroy, Lori McLaughlin, Katie Payne, Debbie Bolin, and Greg Kuderman? Did I do that right? Is he here? I apologize. Kuderman. Again, the paper's coming out in January. It's going to be a great event in Washington, and it's the paper that will spark a number of conversations that will help us get close to building a world-class system of delivery of care. And as we do that, it brings us a lot closer to translating the stewardship principles into practice across our country. So stay in our dialogue and keep coming to our events, and thank you for your contribution. Goodbye. Thank you.
I was just in college.
your mission, and I think you have a great mission, so thank you very much for doing this.
Well, thank you so much.